This conference will now be recorded.
Good evening, everyone. We are going to practice a few stations which are being repeatedly coming in the exam in the OSCE stations every now and then. And the college is fond of these topics. So I selected these one. So the people who are going for November exam, they are a lot who are going for November exam. And they are present here. So all of them should have some chance of practicing and talking. The only thing, most of the people have knowledge because they have passed their part 2 recently or in the last year. But some of them, the only problem is how you should speak and time management. So there are two things only. This can be overcome by practicing. Practice with the mentors and practice with your study partner. So this is the time who are going for November exam. This is the time to practice the recall stations more and more with your study partner. And then because your exam is like a month ahead, of course, together with it, you need more, you need to read also together with practice. But ideally, this is the time for practice. Let me start with the first station. As you all know, 2 minutes is, you have 2 minutes to read and make short, what you call it, bullet points outside the cubicle and 10 minutes inside. So I'll give you 2 minutes outside, and for me, this 2 minutes is very precious. And I want to know how you are making this time effective and beneficial for you, because what you are going to do inside the station depends upon your 2 minutes time outside the cubicle and your bullet points. So I will ask everyone what you will write in your bullet points, please. So Dr. Fatin, do you want to start the station?
Yes, good evening, Dr. Samira. Okay,
Good
I will
evening.
start.
Okay, so I'll show you the station and then you have 2 minutes to write. Okay, your 2 minutes start now. You can go inside, Dr. Fatin.
Yes, hello.
Hi, doctor.
Hello, hi, me Dr. Fatin, registrar in an antenatal clinic. Me confirm your name and age.
Yeah, I'm Sarah Johns. I'm 32 years old, doctor.
Yeah, welcome, Sarah. Nice to meet you.
Thank you, doctor.
Thank you. What would you like me to call you?
Sarah is fine, doctor.
Yeah, Sarah, lovely name, Sarah. Sarah, I came to know from your referral readers that you are planning for pregnancy and you have concern because you had the surgery in heart and you are on anticoagulant, oral anticoagulant. Is it correct?
Yeah, that's true, doctor. As you can see that I have this condition of heart, and then I had surgery. Now, I want to become pregnant, actually. Me and my partner are looking forward. So I just want to know what precautions should I take? What should I do?
Yeah, this is great and nice. I appreciate you for your concern about your health and about your outcome also, baby. Really, you are great mom. You are caring about your outcome. Okay, Sarah, I am going to tell you about your concern. I will talk to you through the cardiac disease with pregnancy, the effect on pregnancy, and also the effect of pregnancy on the cardiac condition. And I will
Okay.
take you through also about how the pregnancy going to be and how to manage you with cardiac disease. And I
Mhm.
will provide also about patient information leaflet and GP later and contact number and support group and website. Is it okay?
Yes, doctor, it's lovely. Okay.
Anything else you want me to address?
Yes, I'm Sarah, doctor.
Yes. Okay. Sarah, could you, is it allowed? I wanted to ask a few questions from you. Is it okay?
Yeah, yes, go on, doctor.
Okay. Sarah, can you tell me more about your heart problem, when it started and how it is going so far?
Yeah, doctor, when I was 12 years old, I had some eye lens problems. And from there, after they investigated more, and then I have at around my when I was 9 years old, it all started, and I didn't know before that, to tell you the truth. So I developed some. I even fell down once, and I had some dizziness. I was feeling very weak, and then I went to my GP. He did some test for me, and he find out that I was having this
Hmm.
problem. So it was going on, and then around like 9 years ago, my cardiologist told me that this is the time to do the surgery. So maybe he did some echos and he find out some problem. That's why he asked me to do the surgery. So like 9 years ago, I had the surgery,
Okay.
and
Okay.
from that
Uh,
time, I started warfarin also.
okay, Sarah. And how you are doing now since your surgery? How is your condition?
Yeah, I'm much better now. I don't have any
Okay.
problem currently.
When you last visited your cardio heart doctor?
It was a month ago.
Okay,
Uh,
any advice, special advice from him?
yeah, actually, he did echocardiogram, which he's doing every now and then, and he told me that it's all fine. There is no problem.
Okay, did you spoke to him about your plan of pregnancy on last visit?
Yes, actually, I talked with him, and he told me that he knows about that. I want to get pregnant, and he sent me and he asked me to go to you because I have some concerns regarding pregnancy, and he want me to talk to you.
Okay, and when your next coming appointment with the cardiac doctor?
Yeah, he told me after you have talked with your doctor, come back to me so that he can correct few things for me and maybe he will change few things for me. But after I'll talk to you, I'll go back to him.
Okay, how many medication you are taking right now?
Now I'm taking a warfarin, which is 5 milligram, and
Okay,
yeah, I'm taking some vitamins, and actually my blood pressure is under control, so uh, nothing else, some vitamins. And he advised me to take folic acid as well, actually.
Okay, fine. Okay, Sarah, did you feel any chest pain, any anxiety, any tired if you did any moving or getting upstairs?
Yeah. No, doctor. My doctor also frequently asking me this question, but I'm fine actually.
Okay, nice. Sarah, this is your first, is it your first pregnancy even before you get pregnant?
No, no, this is my first.
Yeah, are you using any contraception?
Yeah, I'm using I am not using anything. My partner is using condoms.
Okay. Do you remember your last menstruations?
Yeah, it's around 2 weeks ago.
Okay, fine. Lara, Sarah, sorry, do you have any other medical disease you visited your GP recently for any other else?
No, doctor. I don't have any other
Or
problem.
any previous surgery in the past you had, except that part of heart surgery?
Only this heart surgery, doctor.
Okay, what about your family? Any concern in the family, disease of malignancy, blood disease, any else?
No, doctor, I don't have any problem in my family. I'm the only one have this problem.
And how is your partner general health?
Yeah, he's fine. He's good.
Oh,
He has no issue.
okay. Who's supporting you in life, Sarah?
I'm working. I'm working as a secretary and I'm supporting myself. And my partner is very supportive also.
You are living with your partner right now or
Yeah,
someone else?
yeah, I'm living with my partner.
Okay. Can I ask you some personal question? Maybe you feel my question intrude you, but we are asking for all patients in same condition.
Yes, doctor, you can ask.
Okay. Do you feel lack of interest, depression, anxiety, stress?
No, doctor, I don't.
Okay. Are you taking any alcohol?
Uh, yes, occasionally when I'm in parties only on weekends.
Are you smoking?
Yeah, I'm smoking like around 10 to 15 cigarettes per day.
Okay. Sarah, do you have allergy for any medications?
No.
Okay, nice. Okay, Sarah, by the end, I will gather your history. I will summarize all for you. And if anything you wanted to add, just remind me. You are Sarah, 32 years old. You plan for new pregnancy and you have cardiac surgery 7 years ago. And right now you are on warfarin and you came without any complaint, just you want preconception counseling. Is it okay? You
Yes.
are smoking occasional and you are taking alcohol. No others, no other complaint you have. Is it correct?
Yeah. Yeah,
Yeah,
everything is okay except I'm smoking every day 10 to 15 cigarettes per day.
yeah. Okay, Sarah, from your history, I would advise you to stop smoking, as you know, smoking is affect your general health and it also gives bad effect on pregnancy.
Oh,
Hello,
there is sound.
background noise.
So
Okay,
everyone, please
so
mute their mics, please. Everyone else, mute. Yeah. Okay, doctor. So what
okay,
can happen, doctor, if I want to become pregnant? Is that the right time to become pregnant?
okay. My advice for you now, Sarah, try to keep on using contraception till we will discuss with consultant and we will arrange meeting with multidisciplinary team. Cardiac doctor, heart doctor,
Hmm.
and the consultant obstetrician, anesthetist, and
Mm-hmm.
fetal medicine doctor, and all over you also
Mm-hmm.
stop smoking surface and alcohol
Okay.
stopping surface. By the
Mm.
end, while this time better if you continue on using the contraception and start to folic acid 3 months, and we will arrange another meeting to give you to talk to this multidisciplinary team who will guide you. Is it suitable time and your health you are ready now for getting pregnant? And regard also warfarin will take consultation from hematologist because
Okay.
warfarin not also to start pregnancy by warfarin. Might be will change it to another blood thinning agent.
Oh.
Now I will provide you with patient information leaflet, GB
Mhm,
letters to help you and prescribe
mhm,
folic acid in high dose and
mhm,
will register you for NH stop smoking service, alcohol stopping
mhm,
service, and to prescribe suitable contraception for you for 3 months.
okay.
After that, we'll
Doctor?
contact to you and arrange another meeting with you. Is it okay,
Yeah.
Sarah?
Yeah. So your 10 minutes finish, but I want you to finish. So because I have two more questions. So doctor, my condition, what can be the effect of my condition during pregnancy? What can happen to me?
Yeah, as you know, pregnancy itself is overload on the heart. It is stress for the work of the heart. But in adding of there is another cardiac tissue, it will increase the more load on the heart plus the pregnancy also. So the risk for
Mhm,
you, it is you may be cardiac problem, might be arrhythmia, increased heart rate,
mhm,
palpitation. Maybe you will
mhm,
go through the anemia.
mhm,
Plus, also the pregnancy can be complicated by a small
mhm,
baby, maybe small in size,
mhm,
baby maybe preterm delivery can occur
mhm,
like this.
mhm. Okay, doctor, can I deliver normally with this condition?
Yeah, mode of delivery as see Sarah, many pregnancy in such your condition passing fine and healthy if they are follow the instruction and keep on the regular follow up with cardiac doctor and
Mhm,
obstetricians. So most of them passing the pregnancy healthy and outcome healthy and fine. Other thing, there is still risk of pregnancy on the heart. It increase the overload of the heart and affect the heart and the condition can be deteriorated. Plus also
So,
pregnancy itself can be complicated by your baby could be small, could be delivered
mhm,
preterm. And we
okay.
also sometimes we need to deliver you early to improve your condition. Mode of delivery, if you are as pregnant so going safely and healthy, there is no problem if you go in normal delivery unless if
Mhm.
there is any obstetric indications for delivery. During
So from
delivery, there
my
is
so doctor, from my heart condition, it's fine. I mean, it's only the other conditions. You are saying obstetric condition. I don't understand this, but
yes.
it's not from my heart.
Yes, delivery, our aim to achieve you normal vaginal delivery unless if there is any obstetric indication for cesarean section. During vaginal delivery, there is other arrangement will be arranged for you. We will set
Mhm,
you comfortable, good oxygenation, painkiller, analgesic. We will help you during the second stage, not let you to push or become
mhm,
exhausted. We will short the second stage by
mhm,
instrumental delivery. After
mhm.
delivery, also will hydration, oxygenation. Some medication has to be avoided during delivery, as we are. If you heard about ergometrine and these things, we will not give you during delivery.
Okay. So doctor, I want to know more about it. So I will read the patient information what you are giving me, and then I'll come back to you.
Yeah, thank you. Thanks for your time and hope to see you soon in pregnancy file.
Okay, thank you very much, Dr. Fatin. Just I want to
Thank
know
you.
that what you have, what is your idea about, what do you think? What is your feedback about your own station?
Mm, I can't tell Dr. Samira. Maybe I have deficient
Did you
in. You
did
asked
you
me
cover?
about effect of disease on pregnancy, and I feel myself
Hmm.
deficient in this part. Maybe
You mean in knowledge? This is what you mean?
yes,
So my first
yeah,
question
could be.
about the knowledge. So what do you know about aortic stenosis?
Um, Yeah, maybe
Is
less.
it an
I read.
is it a acquired condition? Is it a, congenital condition? Usually, what is it?
Yeah, it is, I think, acquired condition. I didn't read more in aortic stenosis.
Mhm. It is usually in females, it is usually congenitally present. Aortic stenosis is usually is there congenitally, usually. What about what are the risks from the aortic stenosis? What can happen? There is a
Yeah.
problem in aortic valve, right?
Yes.
So, like in mitral valve, this is aortic valve also.
Yeah.
Is there something that they are checking the aortic valve area? The severity
Yeah,
of the
aortic.
condition depends upon the aortic
Yeah,
valve area. Yeah,
dilatation of the aortic valve is measured and taken.
yeah. So if it is less than 1.5 square centimeter, or if the peak ventricular outflow tract gradient is more than 30, then this patient is high risk, or ejection fraction is less than 40%. But for this patient, she is not untreated. Just I'm giving you
Yes.
background knowledge. She has gone through all these problems. She was symptomatic before. She was having syncope. Once so she went to her GP. The GP did some investigation for her, and they find out that she has this problem, aortic stenosis, after doing the echo and everything. Then they find it most probably that it is severe. That's why she has gone through valve replacement. Anyone who has valve replacement is on warfarin, right?
Yes, an oral. Yes.
Yes, is warfarin. So what are the so what you will do once the patient will become pregnant?
Yeah, will it change here from warfarin to low molecular weight heparin, doctor? It
Yeah,
is bridging thromboprophylaxis, what we are saying.
yeah. So we'll do the bridging, but of course we will not use the lay. You already mentioned about will change to some medication. Um, uh, we will change your oral warfarin to some injectables or some injections during pregnancy. You already mentioned about this. Don't you
Yes, I
think
told.
that, yeah, don't you think that, so what are the risks? She has valve replacement. Her valve can deteriorate during pregnancy. She can have again the symptoms can develop for her. What are the complications can happen? You mentioned about arrhythmia. She can go into hypertension, although now she's not hypertensive, but she can go into hypertension, heart failure, even angina, because aorta is the main artery supplying the brain and all the body. So all these things can happen. What
Yes,
about her INR?
it is high, 3.5.
Yeah, so you need to mention this, that because she told you that she's taking warfarin 5 milligram, so you need to refer her to the cardiologist where he might change or increase her dose. So so you said, so overall, generally speaking, you cover most of the points of cardiac disease in pregnancy. But there is only one thing that about aortic stenosis, you don't know much about it. There is not much written about aortic stenosis. There is not much actually. Even if you don't know specifically about aortic stenosis and you know generally about how to manage a cardiac disease in pregnancy, you can do well. There is no problem. You can pass in this station very well if you can manage this station as a cardiac disease in pregnancy. So I want to ask you what you wrote in your bullet points while you were standing outside in your 2 minutes. What are the important issues? Yeah,
Yeah, I put in my.
there are many points because people are writing. There are many points in because you need to cover many points in antenatal, in intrapartum and postnatal. So whenever there is a question of preconception counseling, so you not only do the general and specific preconception counseling, you have to cover the antenatal care, intrapartum and postpartum. But I want to know first what is in your mind, what was in your mind, what are the issues in this scenario? Number one.
Number one, I market she is on warfarin need to be taken decision with hematologist or cardiologist to
The
change.
issue
Here are
I'm talking about, the issues. The first issue she has, that she is post surgery or post valve replacement, and she is a case of aortic stenosis. Most probably she had severe aortic stenosis and she had valve replacement, which was done for her. So this is the first issue, because you need to address all the issues one by one. What is her second issue? As you can see that she is on warfarin. These are two straightforward issues. What is her third issue?
yeah, here in INR is high
INR is
3.5.
high. This is an issue. What
BMI
is her,
BMI is
yeah, what
high.
is her fourth issue, which you did not touch at all, is BMI. So all of the
Smoking and
issues
BMI.
is smoking, because from the history, you came to know that she is smoking, which is a risk factor for
Yes.
heart diseases. So the other issue is smoking. So these are the issues which you need to address. You have to write in your bullet points outside the cubicle that number one issue, aortic stenosis, post valve replacement. Second issue, she is on warfarin. Third issue, her ENR is high, so most probably she needs change of dose for warfarin. Fourth issue, her BMI is 36, class 2 obesity. And the fifth point is smoking.
Smoking.
So you need to address all these issues one by one. So first of all, I want you to introduce yourself. First, you enter inside. Yeah, the type of valve, mechanical heart valve, which has more risk, or the biosynthetic heart valves. We need to ask. The patient will tell you that she has biosynthetic heart valve. So the thing is, so because other, if she is on mechanical heart valve, the risk of thrombus in the valve is very high, and maybe mostly during the organogenesis, you will just give her low molecular weight heparin, and maybe will start warfarin after that, and will go for cesarean section if the, and then at the last 2 weeks to switch her again to low molecular. There is a table anyway. You see, you know this talk article. Have you seen this table? This is what we
Yes.
do. We can give warfarin until first thing. Voice is not clear. Can you hear my voice now?
Yes, I can see.
Yeah, so warfarin until 38 weeks, and then followed by elective. If she's on for warfarin, then she should go for elective cesarean. Or you can give her heparin, as you said, from 6 to 12 weeks, and then switch to warfarin until 38 weeks, and then cesarean section. Or you can give her heparin throughout the pregnancy, but depending upon different risk. This is from the top. Anyway, so whenever you enter inside in a station and you introduce yourself, you first of all, you will say, uh, hello, good morning. I am Dr. Fatin. Your full name. May I know your full name and age, please? Yeah. So yeah. So the answer will be, so she will answer you that my name is Sarah Jones and I am 30 years old or 32 years old. After that, I recommend everyone. So every mentor has different, but what I did in my exams, and what I find, that talking extra things, if you will say extra things, there is no negative marking, but there is a big what you call it, there is a big problem if you are saying things extra, like you can lose your time, which is more worse than negative marking. So if you are saying something extra, you are losing time. I find out that you took 2 minutes only in the beginning, in the introduction and setting an agenda. Setting an agenda is an ideal thing and it is very good, but because there is a lot of things to say in this, uh, to cover in this scenario, that's why I will simply say that do introduction, your full name, and ask her name and age, and then start like this. I can see that you have this heart disease and you have valve replacement surgery before, and you are on warfarin now. You are here for to discuss with me before you get pregnant in preconception. So ask her what is in her mind, what is her agenda. What I mean to say that you should ask all the patient what is her agenda, because she will tell you from her answer sheet what is her agenda. But don't put an agenda like, I'm going to ask you history, a few questions, then we are going to talk about effect of pregnancy and effect of the disease on the pregnancy and effect of pregnancy on the disease, and we will talk about how we are going to manage your pregnancy, and then we will talk about your delivery, and then about after the delivery. I mean, it will take a long time. So simply, if you will see that the scenario is like this, and there are many things to cover, go straight forward. Just ask the patient what is the agenda in her mind, instead of telling what you will do. So setting agenda is very good, but here you don't have time to set agenda. Just ask her what she want. So after you ask her what she want, then please come straight forward and start asking history. You ask about sign and symptoms. You should ask about you ask about sign and symptoms actually, which is very good. Okay. So you ask about any sign and symptoms. If she has sign and symptoms, I mean of heart failure, of any palpitations, any chest pain, shortness of breath, feeling of dizziness, syncope, to make sure how valve is working. And also you already ask about the last time when she saw a cardiologist, or what he told her after doing echo, and she told you that he said everything is okay, your echo is okay and everything is okay. So yes, that is true, that is very important. You ask her. And then in preconception counseling, you divide it into general and specific. Like generally all patients, you ask them to, for example, rubella screening, ask them to start folic acid, uh, at least 3 months before pregnancy, as you said. And if she's smoking, you immediately, when she says smoking, instead of coming back to it later on, immediately at the same time during the history taking, when she told you about smoking, tell her about stop smoking NHS program. In one word, please, in one sentence only, not more than this. Do not talk too much about smoking, because you have a lot of things to say. And then you can say that if you are already vaccinated for hepatitis or chicken pox, and you have taken vaccination for rubella, which is called MMR, you can ask the history, the general history. Specific history, you already ask about the sign and symptoms. And if the general history also, you should ask like, how is her period, what is her smear, gynae history, what I mean, and obstetric history. You asked already if she has any pregnancy before. She said no, I never had any pregnancy before, so she's a nullipara. And then you already asked about family history. Anyone in her family has heart diseases or not? I think you missed that one. And then social history, you ask about smoking, alcohol. Don't hesitate to ask about drugs. You can ask also. And good that you ask about who is supporting you. You ask questions of depression, and how is her partner. So you ask about the social history. And then you ask about allergy. This is very good. You ask about allergy. And when she told you that she is on condoms, her partner is on condoms, uh, immediately at the same time, you have to tell her that you need to have some adjustment before you embark on pregnancy. That's why I recommend you to use some other form of contraception. Like we have uh, a stick which can be put in the arms. I'm talking about implanon. We have some injectables, and we can have some pills with one hormone called progesterone. so that the examiner will know that you are offering her progesterone contraception, not other than this. And then if she asks more about contraception, you can talk more, but you should stop here. You can say that we have other good, more effective contraception, and if you want, I can arrange another appointment for you to talk about contraceptive choices. And then she will tell you, if it is in her agenda that she will talk more about contraception, she will ask you that I want to know about injectables, or shall I take pills, or what is the stick is called, how it, she will ask you. And then when you talk, so you are like talking about the history. You are taking history while you are doing the preconception counseling, because you want to know the background. Now all this thing should cover like in 2 to 3 minutes, 3 minutes maximum for all these things what I said. Then you come to the management, because her concern is also that her concern is how am I going to cope during pregnancy with this heart disease. So please, all of you please mute. Yeah, chest pain, shortness of breath or breathlessness, palpitations, fainting. These are the signs and symptoms. You are writing very correctly. Okay, and ask the New York Heart Association also. This is a good point, that are you able to do your work? Are you able to walk? Are you able to climb stairs without feeling chest pain and shortness of breath? So you will know that what class she is. So generally speaking, she said that I am well, I don't have any problem. I can, if you ask her, she will tell you, I can manage working outside, I am climbing stairs with no problem. So what are the predictors of worse maternal and neonatal cardiac events? This you need to ask in history. Can you see from the TOG article? Can everyone mute their mics, please? So what are, if she ever had heart failure or ischemic attack or stroke, or if the New York Heart Association class is more than 2, or if the aortic area is less than 1.5, and if the ejection fraction is less than 40. Okay. So these are the maternal cardiac events. So the neonatal events, yeah, this talk article I can send you on my this is before, this is not new. I mean, this is like 2011 or something. Yes, I will post these talk articles. There is cardiac disease in pregnancy 1 and cardiac disease in pregnancy 2. There are 2 talk articles. Yeah, so you have to ask about the predictors for adverse neonatal events, like smoking is one of them. And then if she will use anticoagulation during pregnancy. So she was asking you, can I deliver normally or vaginally? So you should know what are the cardiac indications for cesarean section. So if there is aortic, this is usually with Marfan syndrome, aortic dissection or aneurysm. But if she is, for this patient, if she is on warfarin treatment within 2 weeks, then she should go for cesarean section. This is an indication for cesarean section. And if her New York Heart Association is says that, and do you know when to reduce the second stage of labor, Dr. Fatin? When you should reduce, in which New York Heart Association class that you should reduce you should use like some instrumental delivery or something to, or shorten the second stage?
Yeah, in grade 3 and 4, I think. I am not sure.
Yes. So I think it's in New York Heart Association class 2. It's class 2 or class 3? Class 2, I think. It is written in the operative vaginal delivery guideline.
Class 1, no specialties as we act.
Class 1, no. But what about class 2? Is it
class
recommended?
3, I am sure. Class 2, I am not sure.
Class 3 and 4, I think.
3 and 4, not 2, right?
Yes.
Yes, I
No,
said
3 and 4.
Yeah. So if it is 3 and 4, then you will, because you mentioned about reducing the second stage of labor. So I was a little bit confused that because it depends on your New York Heart Association, what is the class that you are giving her.
Yeah, Dr.
So
Samira,
then,
and so when she asked me this question, I could answer here. This answer I can tell you now. After you will meet cardiac doctor, we will decide all together about mood and the time of delivery. I can skip by the answer like this.
usually in preconception counseling stations, the problem is that you have to hurry up. That's why I'm saying no extra words, please. Even no need to say, what do you want me to call you? Just start calling her Sarah. She's only 32 years old. I know many people told me when I was going for exam that these things you should say, these are very nice words. But for me, I never ever ask this question, and I go straight because this will not gain points. So say the things which will gain points and play straight. Just when she say, I'm Sarah Jones, start your station and start calling her Sarah. The other thing is, so you have to finish the pre-pregnancy counseling, which includes history. You should finish the management of pregnancy, labor and delivery, and postpartum. How you are going to finish all these things if you will say any word extra. And when you say something, don't go come back after some time. When she says smoking, at the same time. When you say that I noticed that your BMI, your weight is more and your BMI is very high, so I want to tell you that I will refer you to nutritionist, which I think you already mentioned, and you should reduce your weight because there are many problems that can happen in pregnancy due to obesity for you and your baby, and mention a few of them. You are not going, this is not a viva about BMI obesity, but you have to mention few effects on her and on her baby, because it carries marks. The BMI is mentioned there for a reason, so it carries marks. And you are rightly, when you start management, you rightly mention about the multidisciplinary team, and cardiologist, hematologist, your consultant, MFM, because it's a high risk pregnancy, and stop smoking program. And then you what else, and then you start from the that in the first half of the pregnancy we will do some blood test for you. We will do a special ultrasound for you called anti-scan, and then because there is a risk that your baby might be smaller, then we are going to in the third trimester, then we are going to repeat your scans, ultrasound scans, to make sure that your baby is growing well. And then shortly you can say these things. There is no, and you might need more visits. There is a risk that your baby might deliver early, as you said, and your baby might be smaller than it's expected to be. So in these cases, we might need to deliver you early. So your delivery, is it going to be a vaginal delivery or a cesarean section? Depends. It depends on the condition, on your condition, your heart condition, and your baby condition. This is how you can escape this question. But you can say that yes, if everything is okay, you can deliver vaginally, provided that you are delivering in a hospital. So no home delivery, no midwifery delivery. You are delivering in a hospital. The other thing is that you can go to term, not more than term, and then we will be monitoring you. The heartbeat of the baby will be monitored, and the other thing you can say that there are some special precautions that we can do. We can give you painkiller. You can even deliver under epidural, but we will call anesthesia to make sure that he will adjust the dose in your epidural. There are few medications after delivery that should not be given to you, and after delivery your baby will be seen by the baby doctor will be there, and your baby will be checked by the doctor if everything is okay. And yeah, don't forget about the anomaly scan, and a detailed anomaly scan, and a fetal echo also. So these things, and postnatally, you can talk about even contraception. And there is one thing more, warfarin, because you need to touch the issue of warfarin. She will ask you, but you can tell her also the warfarin. It depends upon your cardiac doctor, your heart doctor. So if you are not very high risk of having thrombosis or blood clot, a clot in your blood, then we might change your warfarin to an injection which is called low molecular weight heparin. This is, so you explain the condition and you can use the medical terminology, but first explain it that there is an injection which is called low molecular weight heparin, which has less risk for the baby, because this medicine warfarin can do some can have some effect on the growth of your baby. So that is why in the first 3 months we might need to change it to the an injection with a more safer medication which is called low molecular weight heparin. And then monthly we will monitor your heparin levels. And do you know that there is a risk of fetal loss also, as you can see here? Risk of fetal loss is 30%, especially if the risk is associated with mechanical valve. So it is, someone said that it is very rightly, someone mentioned that we should ask the patient what type of heart valve replacement she had. If it is a mechanical heart valve replacement, then all these things will come. But if it is a biosynthetic valve replacement, it all depends. Then we can say that, okay, low molecular weight heparin is more safe for the baby. According to new NICE guideline, all class 3 and 4 should be by cesarean section. Okay, thank you very much for this information. So all class 3 and 4 by cesarean section.
Dr. Samira,
Hmm. Hmm. The NICE,
hello,
according to
may I?
NICE. Who is
Dr.
this?
Samira,
Dr. Vidhi? Yeah.
I'm Dr. Vidhi. I just want to ask few questions, if I can ask.
Yeah, please.
First of all, if the patient is on warfarin, the INR is always between 1.5 to 2.5, or it is little higher. The
This one is
maintenance
higher.
INR.
Yeah,
This one is so we maintain.
this one is higher.
Okay.
So we need to mention this to the patient that your INR is towards higher range. And we
So
need to
our
bring it
target will be 2.5. Our target will be 1.5 to
average.
2.5.
Average is 2.5, but until 3,
Okay.
I think somewhere between uh 2 to 3.0 is fine, if I am not mistaken.
Okay, okay. No, because in embolism and all, they write to maintain the LMWH from 1.5 to 2.5. But in cardiac,
2.5.
some
Hmm.
point,
Hmm.
that is, I'm sure, 1.5 to 2.5 for embolism and all, when, acute embolism, when we are giving the therapy. But for cardiac, I was not very sure. Okay, it is 2 to 3 or it is 1.5 to 2.5. I think someone
Yeah,
is writing to 2 to 3.
2.5,
Just we will check.
2.5 to 3. 3.5 is high. The limit which I always know
Okay.
is up to 3.
Okay.
It is up to
And
3.
the other couple of questions, yeah, other couple of question is, if someone is contemplating pregnancy, so should an alternative contraceptive choice will be implant, or because implant is a kind of permanent, it is a long temporary method, because once
That's
it
true.
goes in, it is for 3 years. So can
That
we
is
go
true.
for a COPT or a POP, especially in preconceptional counseling, who wants to conceive, who
Now,
doesn't want to conceive?
now the patient is having 3 choices of progesterone. Um,
Okay.
yeah, the 3 choices for you mean property. There is we should mention about the during delivery, we should be given prophylaxis for infective endocarditis. Whenever there is a heart patient, there is always a risk of infective endocarditis. So we avoid IUCDs in these
Actually,
cases. Hmm.
Okay, because there was a new guideline right now, contraception in heart disease. So
Okay.
there they were saying कि give a long acting. So it has to be put in the hospital setting. So that was one of the thing. And the
So
second
what
is
they gave this copper tea? What is it, 1 or 2 or 3?
I think copper tea is I have to check, but then definitely it is either one or two. It is not
Hmm.
contraindicated. And second thing
Dr.
which I wanted
Samira,
to
Yes, Dr.
if
I
Fatima.
wanted to
uh,
ask.
yeah,
Hmm.
if uncomplicated cardiac valve cover T and IOS are category 1, but if complicated, it become category 2.
Hmm. So it is either 1 or 2, not 3 and 4, right?
No, 1 or 2. Only CHC is 4 if complicated, but CHC if uncomplicated heart, it become 2.
Hmm. So she has one of the option for copper tea also. So what is the best option? Like, yes.
She
No,
is
ma'am, I
one for
wanted to ask
every
you
all
mentioned.
message. She is category 1 for all messages except CHC. She become 2, category 2 for it.
Hmm. Okay.
I
So
just
for
wanted to
her,
clear
because
one.
she want to become pregnant, so
Yeah.
what should be the
Should we
best
mention
contraception?
Implanon? Well, no,
No,
should we be mentioning
I
Implanon? I
think
think
no, actually we should mention Implanon because you don't know, maybe she want to become pregnant after 1 year or 2 years, or and she just want to know from now. You don't know. And maybe she
Yeah,
want
no.
to become pregnant, but maybe you don't know, it's not written. And you don't know when she will
okay.
become pregnant. You can
Okay.
mention one of, but at the end of your list, not in the beginning.
Okay.
Assalamu alaikum.
Okay. And
Dr.
second thing is just a sec. Just infective endocarditis. Actually, now they are saying for all genitourinary procedures, it is not required as per the latest guidelines. So for
Hmm.
vaginal delivery, should we be giving that amoxicillin and gentamicin, which is the recommended ones? Because now for vaginal delivery, they
Yeah.
say not to give. And if the
Yeah, it
patient
was
has
about
had a valve
what I,
replacement and NYHA1,
yes.
then just clear these queries.
Yeah, the thing is about operative vaginal delivery. If she's going for operative any intervention, then uh, normal vaginal delivery, I don't think we need to give. And if there is, as you said, that she is in category 1, she's not high risk. For normal vaginal delivery, there is no need. But what if the patient is going for operative vaginal delivery and we are using instruments?
Yes, Dr. Samira, please, if you can clear this point, which patients of heart disease we should give antibiotics during delivery?
Yeah, what I think that if the patient is going for operative vaginal delivery, this is the time that we should. And there are some specific cardiac lesions that uh,
Oh,
any. I think there are 3 indications for giving
yes,
antibiotics.
what I read,
Yes.
it was cyanotic
Yes,
heart disease. If
yeah,
someone has
cyanotic heart disease. That is true. Cyanotic heart disease, and if
history of
any
infective endocarditis,
history of infective endocarditis, and there is third one also.
so it
Some
means
high
for
risk
every
lesions.
patient we don't need. For
No,
every
not
patient
for
we don't
everyone.
need,
Yeah, yeah, not for every patient. Of course
even if
not.
it is instrumental delivery.
Yes, that is true. Operative vaginal delivery. But if we are doing operative vaginal delivery and if the patient is having all these 3 things, then or one of these things, then we should give the antibiotics. So first one is cyanotic heart disease. The other one is history of infective endocarditis, and I think the third one is high risk lesions. The patient who has high risk lesions. Do you know what are
Means
high risk
which one?
lesions?
No, means
I think one of them is
mitral
Marfan
stenosis.
syndrome. Severe mitral stenosis, Marfan
I
syndrome.
think somewhere I read, I'm not sure if there
Hmm.
is uh, aortic or mitral regurgitation with Marfan syndrome. I think I'm not sure.
I'm not sure that in Marfan syndrome also what is the categories, but whatever is the high risk, if you will read these 2 cardiac disease in pregnancy articles, all of the answers are there. This is talk 2011, and I'm going to post it in all the groups. This is very important to cover the cardiac disease in pregnancy. So if you have read cardiac disease, and you have not finished, you have not read the TOG articles, only guideline is not enough. The guidelines are not enough. You have to read these 2 TOG articles in order to finish the cardiac disease in pregnancy. These are must. These 2 are must, congenital and acquired, and all of the answers are there, believe me. And there is one more, third one also. It's about infective endocarditis, especially the whole article was about it. These 3 articles I read together with the guideline, and I was able to answer all the questions at that time. But of course, you know, things slip from your mind. But for you who is going for exam, you have to finish these 3 TOG articles together with the guideline for cardiac disease in pregnancy. But I want now, after you know that how we are going to do this station, because we are here to practice station more than the, it is very good that we are having discussion about the knowledge point of view, which it covers our knowledge also together with practicing stations. But I want someone else to do this,
Excuse
the
me,
same station. Yeah.
excuse me, Dr. Samira,
Yes, go ahead.
but in intrapartum guideline, new guys,
Mm-hmm.
new nice, there is written that if there is aortic problem and consider high risk, must we consider the cesarean section. There are only 3 indication in which there is a high risk of aortic disease and
Mm-hmm.
and NHY, this one 3 and 4th, and pulmonary
Mm-hmm.
hypertension.
Yeah,
So this
pulmonary
patient aortic
hypertension, of course, is high.
stenosis. So this patient aortic stenosis is, we not say only cesarean section is recommended in this
Yeah,
case?
no, because you know why? You know why? She had aortic stenosis, but it has been treated, and she's
Okay,
not
okay.
having any problem now. I know that if anyone has aortic stenosis, especially if severe aortic stenosis, of course, she should go for a cesarean section straight away. But I'm thinking that because she has been treated, she has valve replacement now, and you should take her like any patient who has valve replacement.
Yes, yes, okay, yes. Thank you so much. Thank you.
Yeah. So anyone who now you know from all aspects that how this patient, how this scenario needs to be treated. So I want to, anyone is talking? Dr. Madhu, are you talking?
Hello, Dr. Samira.
Yeah.
Question. Oh, you then I'll ask.
I have hello.
Yes, Dr. Sina.
Yeah, I have one question. Why, if she is on warfarin, should offer cesarean section?
Yeah, this is, you see, I want to show you this one. If the patient is on warfarin, the first point, until 38 weeks, the patient should be followed by elective cesarean section. Warfarin until 34 weeks. And there is a risk of fetal loss of 30% and fetal abnormality is 6% if she is having mechanical heart valve replacement. This is what is written in the TOG article. But if she is on heparin, even this one, if you start heparin for her and then she's followed by warfarin, but it means that if the patient is in warfarin in the last weeks of pregnancy, then she should be followed by cesarean section. This is what I understand.
Yeah,
As
I
you can
mean,
see.
for that, because warfarin, not like heparin. Heparin effect is short, so risk of a bleeding is less.
You know, you can adjust warfarin.
Sorry,
You
Dr.
can
Samira.
adjust. You can adjust heparin. Yeah.
Yeah,
I'm
I
Dr.
mean,
Shaheen.
Yes,
yeah,
Dr. Shaheen.
sorry.
Yeah, I just want to ask. I think this is the table which is showing the abnormality and the outcome of this warfarin on the pregnancy. This is not regarding that warfarin patient should delivered by elective cesarean section. This is
Mm-hmm.
written by if a patient who received warfarin till 38 weeks and she had
Mm-hmm.
elective cesarean section, she had risk of maternal thromboembolism 4%. Fetal
Yeah.
abnormality can be 6% and fetal
Mm-hmm.
loss can be 30%. While
Mm-hmm.
if she remains on heparin for 6 to 12 weeks,
Mm-hmm.
followed by warfarin to 38 weeks, like she took in first trimester of heparin and followed by warfarin, then she
Mm-hmm.
had 9% risk of thromboembolism fetal
Yes,
abnormality
that is
0%.
true.
And it is not written anywhere that these patients should be delivered by cesarean section.
I want to show you this box, the
Hello?
last box.
Hello,
If the
Yeah.
Dr.
patient is
Samira?
on warfarin treatment within 2 weeks, then she should go for cesarean section. This is cardiac indication for cesarean section. I took this idea from this table itself.
Mm-hmm. But that table which you were showing, that was not like for
Yeah,
that
you are
patient should be delivered.
absolutely right, and I agree with you. But I'm saying, yes, you are right. The patient who is on warfarin, they have risk of thromboembolism, they have risk of fetal abnormality 6%, and they
Actually,
have risk
they
of
want to,
fetal.
yeah, they want to show that warfarin, if taking in first trimester, it is causing 6% fetal problem in the fetal abnormality.
Yes,
But if
yes, because they
she,
are on warfarin continuously.
yeah, that is
Yes.
the thing. This table
Yes,
is
yes,
showing.
this is what I mean. But the question, Dr. Fatin, I don't know who asked that why the patient should go for cesarean section if she is on warfarin. This I want to show this box that it
Yeah,
is one of the indication for cesarean section, especially for this patient.
yeah, because in warfarin, if she's what I can understand, warfarin treatment, when patient will go for cesarean section, we can have planned a cesarean section, and we can give
Yes.
FFP and to revert the warfarin situation in the blood, that INR. If
Hmm.
patient will not be planned and she will go for vaginal delivery, we can plan. We can't plan, and she will bleed in the pregnancy. That is what my understanding is.
Yeah,
In
although it is not written anywhere, but we can make up this, and from our knowledge we can say this
Yeah.
maybe.
So,
Okay,
excuse
I
Dr.
want
Samira, sorry, one question. That
yes.
if it is within 2 weeks, I think they will start bridging before the
Hmm.
cesarean.
Yeah, but so let us do the scenario. Yeah, it should be bridging. That is true. You are right. The bridging should be there, but this question is not about bridging. So let us concentrate on the scenario. I want someone else to do the same station, and
Can
you
I
know
do,
now
Dr.
very
Samira?
well. You know now very well how to do the station. We talked very much in detail. Please, I
Yeah.
want someone else to do this the same station and cover all the
Can I do?
points, please.
Hello, Dr. Samira.
Yes,
Hello? Hello?
yes, yes.
Can I ask a very simple question? I'm asking. I had a doubt. Actually, previously, actually, some people are telling we should ask all patients like, do you know how much is your BMI? Then again, one of friend who is working in UK told me most of the women don't know what is BMI, so we should not ask. So what to be done for that? Should we ask? Means
I don't find any problem that if you ask any patient about her weight or BMI,
directly
there
we
is
can
no.
ask because for the BMI one should have calculated. So general people, do they know in UK ki, this much should be, this much is my height, this much is my weight, and they will be calculated. It's not actually practically they're doing, but it's not possible. But I thought.
Yeah. So if the patient don't know about her BMI, you
Hmm,
can, it is written over there in the scenario, first of all. But if it is
hmm,
not written, you have to ask. And if she doesn't
directly.
know her BMI, ask her weight so that you will have an idea.
Okay, so simply we can ask, do you know your BMI? If she doesn't know, we can ask,
Yeah.
we can calculate for you. Like that we can do. Is it?
Yeah, ask her about her weight. It will be in her agenda. She will tell you.
And one more last question. Actually, you told ki we'll ask about ki what is our agenda. So after introducing, we'll ask her ki what directly we can ask ki what is your agenda or something other sentence we can tell in better
No,
way
you
or
you
this is the.
cannot say agenda. This is in your list that
Ah,
you have to ask her agenda. So you can ask her, so what you want in this consultation? What do you want to know? What you like to know?
hmm,
What shall I
yeah,
tell
yeah.
you? Any word you can say, but not the agenda.
Okay, okay, understood. Thank you so
Yeah.
much.
Okay. So there is one doctor, Dr. Dev. I want Dr. Dev to do this station, but within the time, within 10 minutes.
Hello.
Yes, doctor. Can you start doing the station? Do you want 2 minutes?
Yes, doctor, I'll just take 2 minutes.
Okay, you want to take 2 minutes? Take 2 minutes.
Hello, yes, doctor, I'm ready to start.
Okay, go inside.
Hello, good morning.
Good morning.
My name is Dr. Jyoti. I'm one of the doctor today in antenatal clinic. May I know your name and age, please?
Yeah, welcome, doctor. I'm Sarah Johns, and I'm 32 years old.
Thank you, Sarah. So, from your letter, I got to know that you came here today to discuss about that you are planning for pregnancy. Am I right?
Yeah, that's true, doctor.
So, Sarah, can you tell me anything more about you that why your GP has sent this letter and you have any concerns about this?
Yeah, you see, doctor, I have this disease, my heart disease, and then I got surgery. My valve is replaced around 9 years ago. Now I am on warfarin. Me and my partner, now we are in stable relationship, and I want to start a family. As you can see, my age is also I'm 32 years old, so I'm really thinking about starting a family. So I want to know what can happen to me and my baby, and what are the precautions that I should take, and how is my pregnancy is going to be. So there are very many things in my mind actually, doctor.
Okay, thank you so much for your information. That's good that you came today to discuss these issues, and I will be happy to give you some information about this.
Okay.
So, Sarah, about your heart disease, as you told me, now how you are doing with this? Means you are okay right now,
Yeah.
you are fit and well.
Yeah, doctor, I don't have any problem. Before surgery, yes, I was having a lot of problems, but now everything is okay.
Okay, so you had a surgery 9 years ago. Do you
Yes.
have any information about this surgery? Like what kind of valve replacement you have? Did your doctor told you that they have used any
Yeah,
machine type of valve or any tissue
doctor,
type of valve?
let me tell you something. I know my valve is mechanical valve because he offered me that the synthetic valve can stop working after few years. I don't
Yeah.
want to go for
Okay.
another surgery. So I prefer
Okay.
the other one, which stays more longer, which is mechanical valve.
Okay. Okay. That's good that you know about your condition.
Yeah.
So, Sarah, now you are taking currently warfarin tablet, right?
Yes, doctor. It is around
Yeah.
5 milligram I'm taking.
Yeah. Do you know about this medication? Anything, any information that your doctor told you before starting that this tablet have
Mhm.
any side effects or anything like that?
Yeah, doctor, he's asking me to check my blood test every now and then. I'm having, and he
Okay.
told me that uh, sometimes you might have some blood spots and bleeding from this. If your INR is disturbed, so I can have, and
Okay.
if it is disturbed, I can have some risk of blood clot also. This is what he told me. So he's just adjusting my INR, um,
Okay.
every now and then he's checking.
Yeah, that's good. You have many information about your condition. That's very nice. And you're doing well with this. Sarah, do you try that lose weight sometimes because your weight is little on the
Oh,
higher side?
yeah, I know, doctor. My GP told me several times that you have this heart condition, you want to become pregnant, and now you look at your weight, and I know it very well, but I'm unable to lose.
Okay, okay. No problem. We'll guide you through this. So I want to
Thank you.
ask you some questions about your personal this one.
Yeah,
If you
go
are
on.
not, can you give me permission for this?
Yes, of course, go on, doctor.
Okay. So how is your things at home? Who is supporting you?
Yeah, so I'm working, I'm secretary, and I'm supporting myself, and my partner is supportive also.
Okay. So yeah, so your partner also supporting you. That's good. He knows
Mhm.
about your medical condition very well.
Yes, he knows about it very well.
Yeah, your partner is having any medical problem?
No, doctor.
Okay, that's okay. Right now, you are using any contraception?
Yeah, he is using condoms.
Okay. Your smears are up to date till now?
Yes, last year it was done and it was normal.
Okay. In your family, anyone have the history of clots in the leg or just anything?
Mhm. No, doctor. Yeah, my father was is diabetic and he is on medication. And
Okay.
my mother had is asthmatic, but otherwise no other issue.
Okay. Okay. So I just want to ask you some personal questions. This may be intruding you, but I will ask. I have to ask to my all patients.
Yes.
Do you smoke?
Yes, I am smoking. It's around 10 to 15 cigarettes per day.
10 to 15 cigarettes. Sarah, I want to tell you about this thing. Actually, smoking is not good for health. And as I
Mm.
can see that you're planning to get pregnant, I think
Mhm.
you should try to reduce or stop smoking. And I can
Mm.
give you some contacts of our NHS stop smoking services. They can guide you and they can
Oh,
support you to stop your smoking. Okay?
okay. I'll try, doctor. I will.
Yeah, that's very good. Okay. Do you take alcohol?
Occasionally, in parties only.
Occasionally. Occasionally. Okay, I want to tell you at this point also, alcohol is not at all safe for the pregnancy. If
Mm-hmm.
you try to reduce that also, it will help you to get your
Yeah.
healthy baby.
Yes, doctor. I can stop it because I'm not. I mean, very fond of it, and I can stop it very easily. I'm taking it occasionally.
Okay, that's nice. Okay, so now I will come back to your the proper plan. As you
Mm-hmm.
came here today for preconceptional counseling, so I want to tell you
Mm-hmm.
about this. First, we will make a plan with the cardiologist who is
Mm-hmm.
treating for you the heart condition. Okay,
Okay.
that is a specialist doctor that we have to tell him that
Mm-hmm.
the your current INR is looking 3.5. That is
Yeah.
quite high with this medication, so we
Mm-hmm.
have to bring it to the normal. And
Yes.
the warfarin tablet you are taking right now, that we
Mm-hmm.
have to change it to another medication before
Mm-hmm.
you get pregnancy, because this
Okay.
tablet can have some effects to harm your baby.
Oh, really? Okay.
Yeah. Okay,
So I
there
really
are
want to
some,
change it. Yeah.
uh, yeah, if it is possible by your cardiologist, like specialist doctor of the heart diseases, if
Mm-hmm.
he can plan it, if he can change it for you, and it will be suitable, and it will be it's okay for you, like your
Okay.
condition will not be worst. If
Yeah.
he didn't, if he changed the medication, then
Mm-hmm.
it will be good for your pregnancy plan. Okay.
Okay, doctor.
So after start your and that medication will be same like a blood thinning agent. It will be a
Okay.
injectable called low molecular weight heparin, which is
Okay.
safe for your baby and
Yeah.
safe for you also.
Okay.
But we have to start this on the little bit higher dose because of your disease. We will not give you as a preventing dose. We will give as a treating dose.
Okay, doctor, I understand this. So,
Yeah, okay.
doctor, so I have less. I can understand that I have. If you
Yeah.
change this medication, that I will have less risk. So, what
Yeah.
my disease can have in my pregnancy, what my baby can have, even if I have, even if I have my valve replaced and I am okay, still there is a
Yeah.
possibility that my baby can
Yes,
be affected.
actually,
Hmm.
yes, any mother who is having this heart disease, which she have from the birth, which is we are calling congenital heart disease. These,
Okay.
if these mothers get pregnant,
Hmm.
children can get this disease up to 2 to 5 children in 100
Hmm.
childrens. Okay.
Oh, okay.
So,
Okay.
so that's why when you once you get pregnant, we have to
Hmm.
give you a proper plan of management that we will send
Hmm.
you to the specialist doctor who will do for your baby the
Hmm.
heart ultrasound scan.
Oh, okay. So that they will know. There is anything I can do to avoid having my baby heart disease?
There are no more evidences available, but yes, you can. We will give you the folic acid, which is a vitamin.
Oh, okay. Hmm.
Yeah, that we
Yeah,
can
my
start for
GP
you
told
three
me,
months.
and he told me to start, and actually I
Yeah,
started. He
yeah,
gave me 5
yeah.
milligram of folic acid, and I
Yeah,
started
that's
already.
very nice. Yeah, that's very good. You should start and you should take it every day, once a day dose. That will
Yes.
prevent you from your baby developing many things. Not only the cardiac disease, it can prevent
Mm-hmm.
from the spina bifida, which is called the swelling in the baby neck, back of the neck.
Yeah.
That will also
Okay.
prevent, and
Okay.
this will help you to baby growth. Brain growth also will be developed very good.
Yeah. So, doctor, your time finished, but I want you to finish. So, doctor, what else do I need something extra during my pregnancy?
Yeah, we will after once you get pregnant, we will make a plan for your antenatal care. That will be
Mm-hmm.
it will be start from your dating scan, and we will have a joint clinic management, which is called multidisciplinary team management. We will have
Mm-hmm.
a regular visits with your cardiologist, the heart specialist doctor, with my
Mm-hmm.
consultant led care unit plan,
Oh, okay.
and
Mm-hmm.
we will have one midwifery care plan also. And
Okay.
during pregnancy in your first 3 months, then in the second trimester in the 6th month, and then in the third
Mm-hmm.
trimester we will do for you one scan for your
Mm-hmm.
heart, that your heart is tolerating this pregnancy.
Oh,
like
okay.
uh, like we have to
Like
see
like
that
a echo,
effect
you
of the
mean?
pregnancy.
Like a echocardiogram that I used to have?
Yes, yes. And in that we have to see the any ejection fraction, that is called
Okay.
your heart is tolerating or pumping well during the
Hmm.
pregnancy.
Yes, I know about this. Yes, doctor. Hmm.
Yeah, okay. And then when you reach 36 weeks pregnancy, that is we are calling ninth month of pregnancy, we have to
Mm-hmm.
make a plan for your delivery.
Yeah. So can I deliver normally?
Yes, there is a chance to deliver normal. If you are, as long as you are not having any problems, you are not suffering for any breathing difficulty, you are able to walk without any exertion, you are able
Yeah.
to talk without any exertion, you can
Mm-hmm.
sit, you can do your daily activities. Yes, we can
Yeah.
give you the option for normal vaginal delivery.
And you're saying if I'm not feeling any problem, and if my echocardiogram is okay, and if my doctor allow me, then I can have a normal delivery, isn't it? But it
Yes, but
depends upon my condition.
yes, yes, that will be decided at your 36 weeks
Mm.
consultant appointment. And during delivery, we have to see how is your baby also doing baby well. You have to deliver in the hospital where
Mm-hmm.
consultant led unit is available, emergency
Yeah.
cesarean sections, all facilities available, and the
Yeah.
neonatologist who is special for the baby doctor should be available.
Yeah. So, doctor, I can breastfeed after delivery.
Uh,
All
yes,
my baby will
you can
be discharged with me, or will stay.
No, you can breastfeed as long as after your delivery you have after delivery, as you are taking the warfarin tablet, we can again discuss with our doctors. We can again discuss with your heart specialist doctor, and we can start this tablet from 5th or 7th day of your delivery. And yes, it is safe to breastfeed during warfarin treatment also. No problem for your baby.
Oh, okay. So if they start warfarin for me, I can breastfeed, right?
Yes, you can breastfeed. There is no evidence that breastfeeding with warfarin will affect babies.
Okay, this is good. So thank you very much, doctor. If I want to know more, can I come back?
Yeah, please. And I would like to give you some information leaflets about the cardiac disease, about how you will deliver, and after delivery care, about and I would like to discuss with you about contraception also. So we'll make again another appointment with you, and we can have that time. You will come with the full of information. Then we can discuss again.
Yeah. Okay. Thank you very much. Actually, is Dr. Dev, this is your name?
Yeah.
This is your first name?
Actually, my name is yeah.
Okay, Dr. Dev, I must say that you took this because maybe this is not a surprise for you. And we
Actually,
have
doctor, it is like very uncommon for us heart disease, which is like rare, and it's very less patients we saw. So what to say and how to say it was literally difficult.
Yes, the thing is, if you are not working in a tertiary hospital and if you are not seeing referral cases and you don't have a fetal-maternal specialist unit, but people who are working in fetal-maternal specialist unit, they are seeing every now and then.
Yeah, because my hospital we have patients, but very less patients, and they are means with high risk patients. They are not
What do you
advising to
think,
get them
doctor?
to.
Doctor, what do you think about aspirin? Should this patient on aspirin also?
I think better not to on aspirin. Only low molecular weight heparin is enough. Because she doesn't have risk of preeclampsia, she is doing well, and there is no any risk factors. Yet I think aspirin, because it will be I think not indicated in this case. Am I right?
You know,
Maybe I'm wrong.
while I was reading the TOG article long before,
Yeah.
it was somewhere there to start aspirin also.
Okay.
So what anyone has
Yeah, Dr. Samira,
May I answer?
she has to
Dr. Vidhi, Dr. Vidhi.
First, pregnancy and her BMI above 35. Due to risk factor, it means she is indicated for aspirin.
Even for the risk of preeclampsia, yeah, because she is, but she's 32 years old, right?
Yeah,
Yeah.
32.
So more than 30.
Her age is out of the score. She is priming now.
Priming.
BMI above 35.
Her BMI is higher. Yes, yes.
Dr. Samira, it will depend on her pre-pregnancy BMI because right now she is not conceiving. So she has to be reassessed for the need of aspirin at the time when she becomes pregnant, because there will be one is the nulliparity, which will become the risk factor, and if BMI at the time of conception is more than equal to 35, only then she will be eligible. If she decreases her weight to say less than 35, she becomes 32, then maybe not.
Yes, you are right. So we need to reassess her. The answer is we need to reassess her.
Reassess her. Yeah. Okay.
In the pregnancy.
So, Dr. Samira, how it was? What do you feel?
Yeah. So this is a
Samira?
passing station. Yes, yes, Dr. Sinat. For me, this is a passing station.
Yeah.
Okay.
Yes,
Thank you so much. Thank you.
Yes, Dr. Sinat.
Yes, Dr. Samira. I can see
Yes.
that patient like this who is have a mechanical valve, and actually the cardiology advice will anyway for warfarin. So will continue warfarin. So discuss with the patient of fetal continuity and how the baby expected to be have multiple anomaly, and how we can decrease this, and how is antenatal surveillance for this, and the patient scan at 20 weeks. I think it's important to emphasize this point with the patient, as I expect the cardiology assessment will confirm continual warfarin because she is in a high risk for thrombosis. I can see it is very important to discuss with the patient.
She is high risk for thrombosis. Actually, for patients like this, if we are converting these patients into low molecular weight heparin, we are, because of this high risk of thrombosis, of valve thrombosis, we are putting the patient checking monthly NT10A level to monitor the level of low molecular weight heparin. This is one of the indication. If you
Yeah,
are
that's
putting,
why I was telling doctor that we will send to the doctor and he will assess that it
yeah,
is safe to continue or safe to change the
but
medication.
you know,
So that
because
will
it
be
is,
right.
the thing is that this is not a structured viva, but you cannot bombard the patient with a lot of information. So
Okay.
whatever, and there is a lot to say in this. So we just need, even if you don't say monthly NT10A to monitor low molecular weight, there is no need actually. But if you tell the patient that because warfarin is having some effect on the baby, and we, yeah, yeah, that's
Dr.
true.
Samira,
So
can I ask
yes, Dr.
something? Dr. Samira, isn't it if the patient is on mechanical valve and she's on warfarin, we should give initially bribe bridging, we'll give the low molecular weight heparin for 6 to 12 weeks, and then we'll again restart the warfarin because mother life is more important. She's at risk of thrombosis because of these mechanical valves. And
yeah, this is
yes,
one of the options, but it depends on the
But doctor,
joint multidisciplinary
yeah, but
team.
we are the one to start or cardiologist has to
The
start this
cardiologist
medication?
will start, but
Yeah,
cardiologist
but
will start, but
it's after a meeting. We should have a
and
meeting.
again after 34 weeks you will be again started on lower molecular weight heparin.
Yes, yeah. So all these things, we cannot tell the patient all these things. The thing is, if we say that we are going to refer you, most probably we will change it to another medication which is more safer, but after discussion with your cardiologist. So we will all sit together and we will take care of you during your pregnancy and make sure that what is the best medicine for you. So because you might tell her that we will transfer you to low molecular weight heparin, and then after the multidisciplinary meeting they will decide that no, we will continue her on warfarin. So just leave it for the meeting, the result of meeting, and just tell her that whatever is safe for you, but these are the options can be given to you. Whatever is safe for you, we will do it after discussing in the meeting with your heart doctor.
Dr. Samira, is it for every cardiac patient like this was also high risk patient, shouldn't we recommend her not to get pregnant? I'm just asking.
What are the contraindications for cardiac patient not to become pregnant? If a patient has pulmonary hypertension,
Pulmonary and Eisenmenger syndrome.
Eisenmenger syndrome, and there is one more, I think. I think ejection fraction. There is
Aortic
a limit of
pulmonary
ejection.
pulmonary hypertension.
Marfan syndrome also, doctor. More than aortic diameter more than 45.
Yeah, so not all Marfan syndrome, but if the Marfan syndrome aortic root dilatation is more than 4 centimeter. So there are some. And what about the ejection fraction?
It should not be less than 35. It should be more than 40 always.
More than 40. More than 40.
More than 40. So there are, in different conditions, there are indications for cesarean section according to the severity. Okay, so who want to do the next station? I have a list.
Can I do, Dr. Samira?
Who is this? Dr. Husna?
Yes.
Where I think you joined late. You are not in my list, but yes, you can do. Why not?
Okay.
Okay, Dr. Husna, let me show you the next station. Now you have 10 minutes. Write your bullet points like I told you initially how to write bullet points.
Okay.
So all of you mute your mics except Dr. Husna. Okay, doctor, you can go inside. Introduce yourself.
Okay. Dr. Osman, one of the candidates, I'm ready for discussion.
Okay, welcome, doctor. Have a seat. So you have read the scenario, right, doctor?
Yes.
Can you tell me, can you give me summary of this case?
She has a gravidity para 1+1 with chronic renal disease, 9 weeks pregnant at the moment, and declining Down syndrome screening.
Oh, yes. Okay. So can everyone mute? Can everyone else mute, please? From where this sound is coming? Is it from you, Dr. Husna?
I don't know. Should I mute?
Just try.
Now is okay?
Yeah. No more. Okay. So, so my next question is, doctor, what complications can happen to her and her baby?
First, she's known case of renal disease. Complication to her will be hypertension, preeclampsia, and also worsening of her renal problem. And she will have problem with the protein and urine. So will be if already pre-existing, so it might be worse during the pregnancy because the preeclampsia also worse her condition, and also risk to the baby, risk of anomaly if she's taking any medication which is teratogenic. For example, if she is on AC inhibitor, but if she received preconception counseling or early pregnancy might be stopped, the risk of the miscarriages, then risk of the preterm labor, low birth baby, and low risk of growth retardation.
Yes, yeah, that's true. Okay, so doctor, any other investigations you want to order for her apart from what is given there?
So first I will refer her to the nephrologist for the evaluation of condition and review of medication, and he or she might advise, but I will advise baseline investigation like full blood count to see the level of the hemoglobin, and also I will advise blood group along with the RH factor and antibodies, RH antibodies also. I will do a urine test, a dipstick for the nitrate, protein, and WBC, and also I will do a med stream.
Okay.
Midstream also culture sensitivity, and also I will do urea electrolyte to evaluate her renal function. And also I will do a 24-hour urine urine positive on the dipstick, and also I will do a protein creatinine ratio as well, and also I will do and also ultrasound already down for her, and also I will check her immunity for the rubella and hepatitis B, and also HIV and syphilis.
Yes. So you mean the antenatal and the disease specific investigations you will do?
Yeah, specific in general.
Okay, doctor. So what is your plan for her antenatal care, intrapartum and postpartum?
Okay, antenatal, she will be a high risk pregnancy, so it would be in a consultant unit with the joint visit with the nephrologist and obstetrician. So he already has dating scan, so she declined the Down syndrome, so I will explore the reason behind it, and I will give information about that, and the decision will depend on her choice. If she's not willing, it's okay. And also then I will arrange a scan at 20 weeks, detailed anomaly scan, and also I would start her low dose aspirin from 12 weeks to reduce the risk of preeclampsia, as she is already a renal patient. And also I will regularly, in every antenatal visit, I will check her blood pressure, her urine for protein, and also if needed, the renal function will also repeat it, as if the condition depends on the condition of the patient. And also I will follow her with the midwife plus the consultant obstetrician, and after 28 weeks the test will be repeated, especially she's prone to the anemia. I will check her hemoglobin again at 28 weeks, and also I start iron, and then I will follow her growth scan after 28 weeks every 4 hours. Also for the amount of Lycar and biometry as well. If there is any concern, I can arrange umbilical artery Doppler if is growth restriction suspected. So also we will regularly follow her with the giant clinic renal physician as well. So at the third trimester, we evaluate her in terms of her condition, her pregnancy, and in conjunction with the renal physician, decide about time of delivery, mode of delivery,
Yes.
So she might have normal vaginal delivery if there is no obstetrical indication. So it would be also in a consultant led with the input from the renal physician. And then during labor also will be monitored regularly with the fluid intake and output. And also she will have regular follow-up after delivery. And also she will be seen with the renal physician before discharge. I will advise her about contraception, breastfeeding, and any bleeding, pain after delivery, and also support for breastfeeding. And also review the medication. If the medication was changed before the pregnancy, she can shift it to her previous medication, and then follow up with the in the community with the GP along with the nephrologist.
So doctor, she's 9 weeks pregnant and she's currently on low dose aspirin. So do you think that this is right to start aspirin at that time?
Usually we start aspirin at 12 weeks or after 12 weeks to decrease risk of preeclampsia, but she as a renal patient might be because of proteinuria might be started for that reason. So I will consult my consultant, and also I will consult the renal physician about this option treatment.
Yeah. Okay. Thank you very much. Actually, you managed to finish on time, and this is very good. You covered most of the points, Dr. Husna. And before I will give the feedback, I want to ask you that what do you think, that are you able to cover most of the points, or you want to say something else also?
So I discuss about the risk to mother, risk to the baby, and also I discuss about that it's a high risk pregnancy, needs multidisciplinary team. I discuss about the extra monitoring during the pregnancy plus antenatal checkup, and also I discuss about the.
Discuss about the thromboprophylaxis risk assessment?
Oh. No. This is the important point that I missed, especially it's very important.
Yeah, they are, the college is really what I can say, that they really want to hear this whenever some patient, especially in pregnant lady with any kind of maternal disease, and in maternal medicine especially, and any condition like this, they like to hear the word of VTE risk assessment.
Yeah, it's very important in every pregnancy, especially with this pregnancy.
Every pregnancy, it's important, but especially with the maternal diseases, it become more important.
Yes.
This is maybe, I think this is the only you mentioned about multidisciplinary, and you mentioned about more frequent visits actually, and every time when the patient will come, the need for blood pressure monitoring and protein check. And you mentioned, did you mention about the NT scan? And the anomaly scan, detailed scan?
Yeah. I
mention, whenever you
Excuse me,
mention
doctor,
anomaly
this
scan,
frequent visit means monthly visits. From 9 weeks, we have to start monthly visits.
Now it all depends upon her serum creatinine level. She's a stage 2 kidney disease. So most probably her creatinine, because we are not checking the glomerular filtration rate in pregnancy, we are checking the
Yeah, it is normally rising.
Yeah, so it all depends. Do you remember the TOG article? I don't know if I bring it. No, I didn't bring it. The one which says, oh yes, here it is.
Yeah.
What are the complications that can happen? No, there is one thing more. There is one, no, I did not bring this one. So it is according to the creatinine level. Mild disease, yeah, here it is. Mild means serum creatinine less than 125. Moderate is serum creatinine 1. So risk depend upon the degree of renal impairment during pregnancy. And there is a risk of deterioration during pregnancy. So she might be deteriorated. That's why she will definitely need frequent visits. But how much frequent? It depends upon her baseline investigations. And she will need growth scans also, as we can see that there is risk of fetal growth restriction. So whatever you do, it depends upon the these complications. Like you will check the blood pressure because there is risk of hypertension and preeclampsia. You will check proteinuria because of the risk of you will check full blood count. So Dr. Husna, when you are going to do the full blood count for this patient? At the booking visit and after
Yeah,
that?
at the booking. At
And then?
28 weeks.
Yeah. I think there are twice that you need to repeat it. Have you read the TOG article, this TOG article, from which I bring the slide, the renal disease in pregnancy?
I read many times before. I didn't remember now. Just in my mind that only for twin there is one extra check for the HB on 24 weeks. For the renal disease, I didn't remember. For twin, I'm sure that it's an extra full blood count at 24 weeks.
Yeah, I also cannot remember very well. That I know it's at booking and it's at 28 weeks. Yeah, but Dr. Sharif is writing that it's also at 24 weeks. But just make sure while revising the TOG article. It's just a brainstorming for us that we should confirm while we are revising. So because there is a risk of normocytic normochromic anemia with the chronic renal disease, because of the erythropoietin level is because of the erythropoietin deficiency. That's why normocytic normochromic anemia, and we need to recheck the full blood count. Either twice or 3 times. We need to look at it. While you are doing the anomaly scan, we need to mention that we have to look at the urinary tract to look for the inherited conditions like obstructive uropathy. This is what we need to mention while we are offering the anomaly scan for this patient. Yes, low dose aspirin to prevent preeclampsia is usually started from 12 weeks. So what do you think that why she has been started now? Is it something wrong decision or what?
No, might be right because she might be have heavy proteinuria, because if there is heavy proteinuria, they start aspirin earlier.
I want to ask you, if the patient is having, what is the proteinuria limit when to start the heparin?
Heparin, nephrotic syndrome level, I think.
It's
50. Yeah, it is 5 gram.
5
No,
gram.
no.
Yeah.
No, it's urinary protein creatine ratio of 300, more than 300 milligrams, while albumin creatine ratio will be more than 180.
It's 5 gram per day, I believe.
Yeah, it is
Yeah,
5
5
I
gram. It's
remember
new
also.
guideline. Yeah, 5 gram guideline.
VTE guidelines, 5 grams.
Yeah, it is also written in that TOG article. It is written clearly in the TOG article of chronic renal disease in pregnancy that anything 5 grams or more than 5 grams, we need to start low molecular weight heparin. Okay, so then while you were talking about, so you give summary of the case. It is better to say summary of the case like 35 years old lady, she is gravida 3 para 1+1 and she is 9 weeks pregnant. She is suffering from stage 2 chronic renal disease. No need to say that she is due to glomerulonephritis or whatever. So what is the how you will complete your summary? And no need to say she's on regular follow-up. So you need to pick some sentences from this scenario in order to make your summary. So you will start like 35 years old, gravida 3 para 1+1. She's now 9 weeks pregnant. She's a known case of stage 2 chronic renal disease. Now, currently, yeah, we missed BMI. We should ask about BMI. Currently, her full blood count is normal and glomerular filtration rate is 79, and she is on low molecular weight aspirin and multivitamins. She has a viability scan which shows that she is having 9 weeks viable pregnancy. So in summary, you can just pick few of the sentences from it. Okay, the second question was the effect. What can happen to her and her baby? Yes, she can have hypertension and preeclampsia. Her renal function can deteriorate and she might need dialysis. Yes, she might need multiple admissions. She has a risk of venous thromboembolism and anemia can deteriorate. That's why we need to monitor her. And that's why whenever you say something, you will say she has risk of hypertension and preeclampsia. That's why we need to monitor her blood pressure and proteinuria, and we need to start aspirin from 12 weeks of pregnancy. She's already on aspirin actually, and we can even offer her screening for preeclampsia. You can add this one also. And the effect on baby is, yes, she can have preterm labor, risk of miscarriages, fetal IUFD or fetal loss, preterm labor, fetal growth restriction, and because of these problems, we might need to deliver her early, or
Dr.
she might
Samira,
need to have,
uh,
yes,
sorry to interject you.
yeah,
About this proteinuria screening, I have a
yeah,
question. Since she is stage 2 chronic renal disease, she might have proteinuria due to deterioration of renal disease. So sometimes, as I was reading the TOG article, there was once mentioned that sometimes it becomes difficult to quantify proteinuria in terms of whether it's due to preeclampsia or due to deterioration of the renal function. So should that be mentioned as well while we talk about proteinuria while screening for preeclampsia?
yeah, because the examiner did not ask you. If the examiner asks you particularly about this question, yes, you need to mention. He just want to give you an overview that how you are going to manage this pregnancy.
But
And did you
doctor, during the pregnancy with the chronic renal disease, if her blood pressure is increasing, I think we
yeah,
should not take proteinuria. We should treat as a preeclampsia. A nice guideline is saying like that. Like any blood pressure increasing during pregnancy, treat as a preeclampsia.
So because in renal disease there is already proteinuria. So if hypertension is deteriorating, it means she's having like preeclampsia.
Yes, because proteinuria is difficult to interpret at this level with a chronic renal disease. So that's the reason, that's the matter of contention, I believe.
Yeah, and we need to check her. Did you mention, Dr. Husna, about the urine for culture and sensitivity? I think in every trimester we have to do urine for culture and
Yeah,
especially this
every month, every
every
monthly, I think, doctor. Every 4 weeks
monthly.
we have to do. Yeah.
Yeah, okay. So urine for culture and sensitivity, especially to check for asymptomatic bacteria. So whenever you mention any test, you have to justify to the examiner why you want to do it. So you want to check for asymptomatic bacteria, especially with glomerulonephritis. Okay. So what is the plan? You mentioned about joint clinic, multidisciplinary team, and because she has history of GDM, right?
Yes, we missed this point.
Yeah, you missed this point.
So,
Although people were
so she
writing,
will have a screening in the first trimester, I think.
they are usually high risk patients, so they need screening in first trimester and then again at uh,
24.
24 to 28 weeks. So initially, yes, you are right, Dr. Farah. Initially at 16 weeks and then at between 24 to 28 weeks. And what else? So most of the points were covered. And you rightly said that so whenever we talk about delivery, we have to talk about three things: time of delivery, place of delivery, and mode of delivery. Always remember these 3 points. So time of delivery, what do you think, Dr. Husna? Can we allow her to go beyond term?
No, I don't think so. Because if she reached maturity 37 weeks and if she doesn't start spontaneous labor, so we should discuss with the consultant and also
37
nephrologist after 37 weeks.
Yeah.
No, we should deliver her at I think 40 weeks, doctor. If
Yeah,
it is
so
blood pressure is
don't
controlled
let
and her RFT is normal, she can deliver at 40 weeks.
Yeah. But my question is that are you going to allow her to become post-dated or not? This is my question.
No.
No.
Okay. So that's it. Until term, she can go. That is true. Until term, she can go and she can go and deliver until. So what about serum screening for Down syndrome? Shall we offer or not?
I think we first explore the reason why she refused. Then we can offer, if she missed first trimester, we can offer second trimester, triple, quadruple, and also we can if she's willing, we can do in the second trimester if she missed first trimester screening.
So if I will tell you that I don't want to do serum screening in this patient, just want to do what you call it, maybe nowadays NIPT people are doing, non-invasive prenatal screening, and then because the result is more than 99% reliable, and then if it is positive according to the gestational age, risk is high, then we go for invasive testing. But serum screening is not reliable in chronic renal disease patient. This is the thing.
Okay, you are right, but non-invasive prenatal testing is available on NHS, Dr. Samira? Is it free of cost for everyone?
It is expensive. We just need to mention it, but we have to say that if it is not available, we can offer patient NT, knuckle translucency, as serum screening is not very reliable in chronic renal disease. We can say this to the examiner.
Okay. Thank you.
Yeah.
Excuse me, Dr. Samira, one question I want to ask.
That this is a passing station for you mostly.
Still, I don't understand why the patient is initially on the low dose aspirin. Still, I not understand.
Yeah, we are just, to tell you the truth, doctor, these are from the recalls. And I took these scenarios from the recalls.
Yes.
So it is like this. Maybe what the information what is given here maybe is wrong, but it was written like this. This is a feedback from the candidates. So we just need to figure out. So we are not creating it.
Hello,
so we need to
doctor,
figure
I
out.
just want to ask you one question. Like structured YY in this case scenario, we have to wait for the examiner to ask for next question, or we can start to tell our management plan?
Because the examiner said a very vague question. He said, what is your plan for her antenatal management, intrapartum and postpartum? So a very
So
big
we
question.
can start to tell. Okay, yeah, that's why.
Yeah. So a very big question, and because he already asked you, he might intervene. Like I think I intervened 2 or 3 times in between. But he can intervene, but he already asked you a question. So you need to keep an eye on your time, and you need to finish until postpartum.
Hello, Dr. Samira.
Okay. Thank you.
Hello, Dr.
I think,
Samira.
yes, Dr. Sina.
Yeah, one question, please. You can clarify again which not reliable. You mean the combined test or the fetal DNA test is not reliable screening for Down?
The serum screening for Down syndrome, which we are doing in first trimester, second trimester.
Combined.
I think the first trimester is PEP A and SCG, and in second trimester is a 4 test, estriol and alpha fetoprotein, and what is the third one? SCG,
Yeah,
and there is more.
yeah, it's not was
Yeah,
renal.
inhibin, sorry.
Yeah, it's not reliable. Renal disease.
Yes.
Okay. And what about fetal DNA? We can offer fetal DNA, free
Yeah.
fetal. Yeah,
Yes.
it's
We
okay.
can, because I read the article of cell-free fetal DNA, I did not see that it is not reliable in chronic renal disease. It is not written.
Okay, fine. Thank you.
Okay, and of course you need to explore why she doesn't want to do it. So you have, because it's a structured why, there is no patient in front of you, so you cannot ask this question. That, but you can say that I will explore that why she is declining screening of Down syndrome. I want to know, and still I will offer her the anti-scan, and if it is available, I will offer her NIPT, and if the risk is high, maybe we'll go for the invasive testing. We can say something like this because the patient is not, the role player is not in front of you. With the examiner, then you need to be in a different mood of questions. Yeah, that is true. If there is a lot of prompting, the if there is a lot of prompting, there must be negative marking. That is true. Yes. Maybe she want to keep the baby. You are right. Maybe this is the reason of her declining. That she want to keep the baby even if it is Down syndrome. So she find no point in doing it. So you have to mention to the examiner that first I will explore the reason why she is declining the screening, and I will explain her about her pros and cons, and if she agree for doing it, then I will offer her. We can say something like this. Okay, so who is the next in the list? So I want to know, before we move to the next station, we didn't complete the safety points. So every scenario in RCOG has, you cannot pass a station if you don't fulfill the safety points. So Dr. Husna, what are the safety points in this station? There are like 4 or
Safe
5.
safety point in this patient was detailed scan and also doing an extra hemoglobin, joint clinic, multidisciplinary consultant plate, high risk, and also doing blood pressure, urine for protein, and also you have urine culture sensitivity to screen for bacteria, asymptomatic bacteriuria, and also delivery plan, place of delivery.
Three things are generally important in all safety points. 3 safety points are generally fit for all stations. Referral to the consultant or to the multidisciplinary team. The second point is allergy, asking about allergy, and the risk assessment for venous thromboembolism if she's pregnant. So these are the general safety points in more or less all scenarios. And then there are specific scenario safety points also. Like you mentioned that that you have to extra check GTT because she has history of GDM, because there is risk of anemia, because there is risk of fetal growth restriction, you will do growth scan, because anomaly scan you will especially look for this inherited condition for the urinary tract, and you will frequent visits. And so this is something extra you are doing for her. We will check her blood pressure and proteinuria, and accordingly, and aspirin also, to prevent the risk of preeclampsia in this patient. So there are like 4 or 5 safety points in this scenario. Safety for her and safety for her baby. That is true. Okay. Who else want to do the next station?
Okay, doctor, I can try.
Who is that, Rania?
Yes, I'm Rania.
Okay, Rania. Let me check the, yeah, drugs. And also there is one important thing about safety. Medication. What medication she's taking during pregnancy, is it safe or not? This is another. And if she is on like AC inhibitor, or if she is on ARBs, then we need to change it, refer to her physician and change it. This is also a safety point. Rania?
Yes, doctor.
I'm giving you 2 minutes now.
No, I don't. I think so. I will not do this. I didn't read surgical note up to now. Any one of my colleagues can do it.
Okay. So there are some people who want to
Anyone
do it.
good at
Yeah. There's someone who just write that Dr. Pinjurina. Do you want to do it?
Yes, doctor.
Okay. So how can I pronounce your name?
Yeah, I'm Nagamani. Basically, I'm Nagamani. That's my surname.
Okay. So your name is Nagamani. So I will
Yes.
call you Nagamani. Okay, doctor.
Yes.
I'll give you 2 minutes. Is it okay? You can do this station?
Yes, yes, 2 minutes.
Okay.
Actually, I don't know anything about surgical knots. This may be the station bullying or under.
I will tell you something. Even if you don't know anything about surgical knot, I cannot see how you are tying a knot over here. I just want to know, do you know how to do a teaching station or not?
Okay.
Okay, 2 minutes.
Hello.
Okay, doctor, you can start.
Yeah. I'm Dr. Nagamani. I'm one of the ST5. Hi.
Yeah, welcome. Welcome, doctor.
Okay, so can I know your name? I think you are FI2.
Yeah, doctor. I am Tamara Johns.
Okay. Okay. How are you, Tamara Jain?
Yeah, I'm doing fine, doctor. And actually, you know the reason why I came here is you can see my assessment form is with you, and I just want you to sign my form that about the especially about the surgical knots time. So can you
Okay.
sign off for me?
Yes, Tamara. But before signing, I want to discuss something about you. Okay.
Okay, okay.
Okay. How are you doing, Tamara? How are you in your unit?
Yeah, so my unit is very supportive and they are teaching me. I'm very happy actually. I don't have any problem.
So since how many days you joined here?
Yeah, so I am in my second year actually. I finished my first year.
Okay. So is everything is fine?
Yes, everything is fine, doctor. I don't have any problem.
Mm.
So, doctor, regarding my not tying, because I have many things and you know I have to many other things that I need to do. So can you sign off for me by at least the not tying so that I can concentrate on other things?
Yes. Can you show me how you do that surgical knots? Can you show me once?
Oh, okay, doctor. So, doctor, this is, I think, the reef knot, and this one-handed, and this is with two hands. This is what I learned. And then there is a surgeon knot, and if you are working in a pelvic model, then how to do it in pelvis, in deep pelvis, how to do instrument knot also. This is what I learned from my seniors. So this is how I'm showing you. So by the way, he's doing wrong, she's doing wrong knot tying. So what you will do? So is it okay, doctor?
It's okay, but I will learn you more.
Oh, okay. So it means that there is something wrong with it.
Samir, I don't know exactly because I don't follow. So I will
Yeah.
do one more station.
No. No, go on. Okay, so why don't I try Dr. Sheriff? Okay?
Okay. Okay. Sorry for that, Samira.
No, it's
Uh,
okay. Now you can listen how Dr. Sheriff will do it.
okay, actually, I also I have no idea about these surgical knots. I read it long time ago, but I will try my best. I want to know my defects.
Not
This is much
the
more
thing
better to
is
make mistake here
it
rather
will
than
come.
doing the exam.
That is true. This is the whole point. Yeah.
Yes.
So do you want 2 minutes or do you want to
No,
start right away?
I will start right away.
Okay, doctor.
Okay. Hello,
Hello, doctor.
I'm Shreve, the ST5, and you?
I am Tamara Johns, doctor.
Nice to meet you, Tamara. So
Thank
I
you.
believe that you are joining with us here short time ago in our unit.
Yeah, in your unit, I am new doctor, but I have been, this is my second year actually.
Okay, so how things are going on in there? Everybody supportive?
Yes, everybody is so supportive and I'm very happy actually. They
That
teach me a lot and they are trying to, they're pushing me, they're brainstorming me and they offer me support. I'm very happy.
Yeah, it's very nice to hear that. Well, Tamara, I understand that you are here today to know more about the how about tying of the surgical knots. Is that correct?
Yes. Yeah, that is true actually. I have been practicing um, uh, quite some time. So
Good.
I'm wondering if you can sign off this form so that I can concentrate more on other things.
Yeah, we will talk about this in a moment, but just let
Okay.
me know exactly what do you know about the tying of surgical knots?
Yeah. So, doctor, I know that there are like what I read somewhere that there is a knot called reef knot, and there is a technique of single-handed and with double hands you can tie, and there is something called surgeon's knot, and there is something called with the strument. You tie
Yeah,
with the strument. Yeah.
excellent, Tamar. Excellent. That's very nice to hear from you that. Well, first of all, I would just like to tell you, Tamara, that there are some indications where you can apply the surgical knot, other indications for tying the reef knot. But our discussion today will be concentrated on the surgical knot, on how you tie it and when you tie it, and the technique used in this procedure. For example, if you have some tissues where there is a bleeder point which is not coming by the simple knot, you have to tie the surgical knot in a way like doubling the knots. These knots can be tied either by your hand, double hand, or by single hand, or by the an instrument. As I show you here, this is the threads here. You are making like that, then you are doing like that, then you are doing like that.
Yeah. So,
Okay?
doctor, can I try?
Yeah, sure. Hold it like this. Can you show
So,
me?
doctor, yeah, this is the reef knot what I learned.
Yeah.
Okay. So, doctor, are you happy with how I'm tying it?
Well, at the first steps here you have done, I noticed that you have done it in a correct way. That's very nice. But I just have some comments if you would like to allow me to do so in front of you. Is that okay?
Oh, so you mean there is some problem in my
Yeah, just
technique, right?
yes, exactly. As you do this one, this is correct, and this step also correct. But at this step, you should bring the thread like that instead of bringing it like that. Am I
Oh,
clear?
okay. Yeah, yes, doctor. Yes, I
Excellent.
understand. And doctor, what about surgeon's knot? Can I try also?
Yeah, sure. Here is a surgeon knot, as it is different from the reef knot in that way. You just like do like that, and then bring the thread like that. And at this point, it will be different from the reef point. Can you try, please, in front of me?
Yeah. I forget what's the next step. I think maybe, doctor, because I have a wound in my finger, that's why I'm not able to tie it properly. Maybe.
No problem, Tamara. We can arrange another meeting to show you how these knots are being tied. I will provide you with some videos and some articles on how you tie and how you apply these knots. So, how do you think the session go? Can you tell me what have gone wrong and what have gone good and what have gone not good?
Yeah. So, doctor, actually, I came for this my AOP, which is the assessment of performance form for you to sign off, because I really want to finish with this and I want to start to concentrate on something else.
Okay.
And
Okay. First, yeah, I would be pleased to sign off for this for you, but actually, you have to be supervised first while doing it. Then you have to do it on your own, and then when you reach the competency, at least we have to be seen by your educational supervisor, and will be signed by your consultant. This is what's called the OSATS form, and after that, you can sign your competency after you do it supervised and 2 or 3 times at least.
So you mean that you can allow me to go to the theater directly, or do I need to practice it before?
Actually, you need to practice it first in front of me, and when you become competent with this tying of this knot, we can sign for you the OSAT. After that, you can do it on your own.
Yeah. So, doctor, after you will sign me, then you will allow me to enter theater, or you can allow me to enter theater before signing off even?
Well, I would like to allow you to enter the theater, but actually we have to sign the OSATs first that you are competent to do it on mannequin. Then we can do it in theater.
So doctor, so we have our skill lab. So you recommend me to go there and try over there, but there should be someone to teach me. So maybe I'll come back to you once I practice
Yeah,
there.
sure. You come back to me and we can arrange another meeting and session to learn more about how tying a surgical knot.
Yeah. So there are any videos, doctor, that I can see
I'll
while I'm
provide you
practicing
some,
at
yeah,
home?
sure. I'll provide you with videos and some articles about how you can tie this one, and I will arrange another meeting with you again to check what more learning you have done.
Yeah. So doctor, can you tell me more about the sutures and the types of knots? Is this information is enough what I told you, or there is something else?
Yeah, there is a lot of information regarding this issue. It's not up to my mind right now. I can review and I can come back to you again and tell you more information about this.
Yeah. Okay. Thank you very much.
Well, actually, I know that I've missed a lot of informations in this issue, but I don't know if I'm faced. Of course, sometimes we are facing strange stations in the exam, and I think we have to manage the situation, whatever.
Yeah, so you have to deal with the situation, whatever it will come in the exams, because this thing can come in the exam.
Yes.
When it came in real exam before. These are all recalls actually.
Yeah, I
But
intend to do it when I don't know any information to see myself how I react. That's all. And sorry for because it's wounded. Next time I will ask about your finger.
Yes, you didn't show the empathy, and you didn't ask how it
Yes.
happened.
Yes,
So
yes.
how is it going? Is it healing well? Do you need any help? Something. So
Thank
that
you, Dr. Samira, very much.
so really the whole thing goes well. And I think that because you will take some time to teach the FY2 how to tie a knot, so your time will finish. And you manage to do it within your time limit actually. But maybe the problem is you are suffering because you don't know much what to say
Yeah.
in this
Yes.
scenario. This is not the problem that time is running out. Maybe you
Yeah.
want to say more, and of course, what are the points that needs in teaching station? What are the points? The first point I want to hear from you. The first point, for a good teacher, what should be the points? First of all, you introduce. You ask her agenda, what she want. So you did very well. You introduce, you ask her agenda, what is her expectation from this meeting. Okay, the third point, you ask her to do it in front of you because she said, I have practiced and I have been doing it. So you ask her to do it. While she will do it wrong, and then you teach her how this is the right way, but in a way that not to discourage her. This is exactly what you did. I'm happy that you said that the first step you did is correct, and I'm very happy that you know how to start. But there is some problem which you will learn with time. There's no problem. What you do, this is the correct way of doing it, and there are RCOG videos about it, how to tie a surgical knot. I will forward you. You can look at it in your website also. And the other thing is there are in our skill lab we have mannequins, so you can go and practice over there after looking at the. And for me, I'm available anytime. You can call me, and then whenever I have time I will call you, and I will let you do it in front of me again. So there are three things. So RCOG videos, and the skill lab, practice in the skill lab, and then supervised, under supervision, you will see how she is doing. So there are three ways of learning, of teaching her. And every now and then, this is good that you have been encouraging her. You said, excellent, what you have done is very good. Good that you know about the background information about the knots, and you know about, so you are encouraging. So although she is doing it wrong, but you are still encouraging her and you are saying whatever she has done right, you are encouraging her for this and you are appreciating what you have done right is very good that you know this information, but there is some problem which will be taken care of and you will learn with time. I don't have any problem in signing off and I will sign off your OSET form. But let me write few comments because she will insist for you to write something or to, so you can say that I will write few comments and but you really need to work on it and you come back to me and after you I will sign your OSET form and your assessment of performance form. After that you can come to the theater. So my question was, you will I can come to the theater without sign off? So if you will say yes, then maybe it might be a problem. So whatever you said is very good and I'm happy about it.
So what do you think about this section?
Yeah. So there are what you can say more that there are two because she want to know about the sutures and the method of the names and the methods of tying knots. So you can explain more about this and the
Yeah.
sutures. You can say roughly if you have not read it even, that you know it very well that they are absorbable sutures and they are non-absorbable sutures. Usually
Yeah.
we are using absorbable
Not just
sutures.
problem.
Yeah, and you can say few whatever you are using, like there is monofilament we are using and the use of it, like monocryls we are using for the subcuticular while we are closing the skin, and we are using there are
Hello, excuse
absorbable
me,
one
doctor.
which can be
Yeah,
braided.
hello.
Yes, doctor.
Yeah, in teaching session like this session, if she said that I can come to OT to see or to do it, I think we can say that whenever I'm in OT, you can come and you can
Just
observe
for
that how I am
observation.
doing.
Yeah.
Yeah, which sutures where I am putting, and these sutures how they are helping to
Yeah.
secure the bleeders and secure the proper knot tying. So I think that will make her happy, or maybe that will be make her
You are
confident,
right.
right?
She can observe, but she wanted to do it, so he discouraged that we cannot allow you to
Yeah,
do
I
it.
think,
First let me
yeah,
sign.
yeah,
But
that we
she
have
can,
to make sign of first. Yeah.
yes, but she can observe. You are right. And also you can ask her that if she has attended the course for the basic surgical skills or not. It you can ask also. And to make repo is good. Always how you make repo with her was very good.
Dr. Samira,
Samia.
one thing, we can sign the formative OSAT for the trainee, but we are not in a title to sign the summative OSAT, because the summative OSAT should be signed by consultant. And
You mean ST6, ST7, not by ST5. This is, you want to, you are emphasizing on the point that what are the parts that as an ST5 we can sign, right?
yeah, because I heard that we can sign formative OSAT, but not summative OSAT.
So, and what are the formatives and summative? Can you give example, please?
Summative, I think, is the competency that you can do independently without supervision. And formative is the learning period that you, under supervision, can do simple things like, I'm not sure exactly, but I think that is competency that you can do individually without supervision competently.
So this surgical knot tying, an ST5 can sign off or not?
I'm not sure, Dr. Samira. That's why I ask you.
Yeah, if ST5 is not competent to sign off, I think they will not bring it in the exam. It's a recall question.
Okay.
So I'm to tell you the truth, Can anyone know more about formative and summative, and what is ST5 can sign and what ST5 cannot sign? Can anyone?
Because as I
Hello.
remember, okay.
Yes. Yes, doctor.
Dr. Samira, I think the summative forms are OSATs. They can be formative and summative. And the other summative form is like AOP. That is also summative. But the formative, they are like CBD and minisex. They all are formative. Then ST5, they can sign off for FY1, FY2, and ST1. And ST2 also. ST5, they can sign. But for summative form to sign, there are certain things like Dr. Sharif said that it has to be first done under supervision, and then it has to be done. I mean, there are 3 steps that it has to be completed. Then only it has to be signed. But ST5 can sign, but it cannot sign immediately. Like in the first meeting, they cannot sign. I think.
Especially if she's not doing it correctly.
Yeah, if she's not doing it correctly, means then they can write some comments, and then they
we
can
can
say
write
that yeah, they can write comment, and then they can say that first you have to sign it off. First you have to you observe it, then you have to do it under supervision, and then it has to be signed off. But that sign off to be completed, one should be consulted. ST5 can sign, but for it to be completed, there should be 3 signs, and one should be of consultant.
Yeah, this is what I was wondering, that yes, ST5 can sign, but it should be countersigned by the consultant.
Yeah, because there should be 3, it should be signed by 3 people, and out of these, 1 people should be consultant. But ST5 can sign for FY1, FY2, and ST1 and ST2. Till the level of ST2, ST5 can sign one of the form. But then that will not be done as a completed for her submit. I mean this thing, and in the first meeting also they cannot sign. They have to say like this. Like if it will come for us in exam, we have to say the same thing, that first you have to do it. You have to first observe it. Then it has to be done under supervision. Then only it has to be signed by 3 people, including one of the consultant. So then it will be completed.
This is very good information. One thing more, doctor, that this the patient, the FY2, can she do it in OR?
No, I think
Even
FY2
on
they
the
are not
patient?
allowed to go in OR.
Yeah.
They can only put the cannulas. They can take the samples. They are not allowed to go in OR.
You
Because
mean
they are
even
not yet
observation, she cannot go?
No. I think they cannot go. I'm not sure, but because they have
No,
not
no,
started that
doctor.
training in
They can
gynae.
observe. They can go in operation theater and they can observe. I have seen 1 of 2 stations they're like this. They can observe, but they are not allowed to perform the procedures.
Yeah,
But the FY2 is a house surgeon. That is not. They have not entered into the gynae. The FY2 they are house surgeons, means they are rotating. It's like internship. It's not. The gynae is starting from ST1. That will be the training starting is from the ST1 level. FY2 level is still a house surgeon level. They are like our internship, like they are rotating in every department. They are not specially for the they have not enrolled for the training of the gynae. That I'm sure.
So there is a question that she can go to theater to observe or not. And it's like a brainstorming question for us, because I'm not sure, to tell you the truth.
Yeah, that I am also not sure whether they can go for observe, but they cannot do. I think
anyone can go and observe, to tell you the truth. But I don't have any problem, to tell you the truth.
Because doctor, there were many questions we were reading, like in scenarios or somewhere, like there is a FY2 on ward on call rounds, and he have to see the post-operative, pre-operative patient, and he knows about the procedure.
yeah,
He's reading the
that
case
they
notes.
can do.
So I think this FY2, FY1, they are allowed to observe in OT. I think. I'm not
I
sure,
guess,
but
Because
logically,
they
I
are
don't
only
see any
intern.
problem.
They have not actually FY till FY2. They are not enrolled into the gynae training. They are house surgeons. They can go to the wards. They can go to labor room. They can put the cannulas. They can observe the patient. They can do all these things, but they cannot do anything specifically for that gynae trainings. Like they are not, I think, allowed to suture episiotomy, or they are not allowed to go to OR. I think they are not allowed, but I'm not sure, but I think they are not.
This is for sure that they are not allowed to do episiotomies or to deliver patient. They can observe, they can help, but
Yeah.
in
Yeah,
theater,
there they can
the
observe.
question is just to go and observe from away, not doing anything. For me, I don't think that there is any problem, but for the people who worked in UK, maybe they are the one who can answer this question. I am not pretty much sure about it, that they cannot even observe.
Dr. Samira, I have a
Yes.
question, please.
Yes, Doctor. Amani?
Regarding this role player, actually, I felt a little bit weird because she's not concentrating on the session of teaching. She's just more concerned about signing the paper, and she's in hurry.
Yes, that is true.
She gave me a sensation that maybe there is something, a hidden agenda.
Yeah, she is carefree. This is the problem. She want to finish. Although Dr. Sharif already asked her that if there is any bullying or undermining. Yeah, but there was no bullying, because she should have at least give some clue. She did not give any clue. So this station was not about bullying or undermining. There can be stations about bullying and undermining, especially with the junior colleagues. There can be stations, but this station was not about bullying, not about undermining. It was just that she's carefree and she want to finish. Yeah. So you need to engage her more, like what Dr. Sharif did. He engaged her more and more and asked her to practice more and more and support her, and she was happy at the end, actually. This is exactly how Dr. Sharif did. This is how it is. But maybe I'm also having, I think, from where to read about this, what are the limitations, for example, ST5, or what he can sign off, and is it in the strategy?
Doctor, actually, that study MRCOG Telegram group, Dr. Somya has posted very nice NHS
Yes.
matrix. It is in very
Matrix.
detail. It is
Yeah,
nicely
yesterday she
showing.
shared.
Oh, yesterday
Yeah,
only.
yesterday
And
she shared everything.
yeah, and it
Yes.
is written that ST1 is the specialty trainee. So F1 is a first year or foundation year. So this
Foundation year, yes.
foundation year means they are
House job
enrolled
now.
in all service, all where all post they
Rotations. They
are
are coming for
posted. Yeah.
rotations.
So they are posted. This means they have to take all orientation, theater orientation, ward orientation. I think they can come in theater, I think, because before you are entering in specialty trainee, at least they will have some idea about how is the theater, how is the labor wards, how is
This is what I'm
wards.
thinking, that logically she can come and observe. This is what my thinking is, without looking at without reading.
Because in our country also, like intern students, they are coming in operation theater. They are just observing the procedures, but they are not doing anything.
Yeah, that is true. So maybe this is how it is. We all of us agree on one point, that she can come and observe. And this is very nice. I will have a look at this, Dr. Somia, what she has posted yesterday. And so
Yeah, it is very nice.
all
Everything
of
she
you
have
should read.
posted about. Yeah,
Yeah.
formative, summative, she have posted very nicely.
Yeah, because people are usually confused about this. Okay, there is one doctor is writing, confirm with a friend in UK, FYs are allowed in operation theatre, but they need competence to do the procedure. So they are allowed as an observer. This is Dr. Maha. She confirmed with her friend in UK. MashaAllah, very fast, very competent. She just
Oh, that's nice. Thank God.
contacted her UK friend.
So fast.
Mashallah. Okay, so who will do the next? Dr. I have in my list Dr. Sohair, Dr. Priyanka, Dr. Najwa, Aksa, Jyoti. Who want to do it? Who is available now? Dr. Lubna?
Shall I do it, ma'am?
Doctor, are you going for November exam?
Yes, ma'am.
Okay. Let me show it this one. Are you okay with it?
Okay, ma'am, I'll try.
Okay, you have 2 minutes. Okay, just go inside.
Okay. Hello. I'm Dr. Ramya, one of the senior doctor in the clinic. Can I confirm your name and age, please?
Yeah, welcome, doctor. I'm Sarah Johns. I'm 19 years old.
Okay. Hi, Sarah. How are you doing today?
Yeah, I'm doing fine, doctor. Doctor, I'm
Okay.
just very much worried that I am pregnant, and and you know that I'm having this, as you can see in my notes, that I'm having Marfan syndrome. Is it going to affect my baby or me?
Yeah, Sarah. There are chances, Sarah. I'll be explaining you in detail. But just before explaining, just before me explaining you, is it okay if I ask you a few details and then I'll proceed you about the management?
Yes, doctor. You can ask.
Okay. Thank you, Sarah. Sarah, is it a planned pregnancy?
It's actually unplanned, but it's welcomed by me and my partner, and he's happy actually, and I'm happy too.
Okay. Congratulations, Sarah. And about your medical problem, as you are telling, you are having your own case of Marfan syndrome. Can you explain me in detail what all problems did you have? How was that diagnosed?
Yeah. Yeah, doctor.
How
So,
was the
doctor,
diagnosis?
when I was young, very young, I don't remember exactly, around 9 or 10 years old. So I developed some problem in my eyes and my lens, and then the GP referred me, and by this referral and by doing some test, then he find out that I am suffering from this Marfan syndrome, and it's not only me. I have some other people in my family who is suffering from this also.
Okay. Yeah, Sarah. Did you have any surgery done for this? heart surgery or any other surgery done for this?
No.
Are you on any regular treatment for the heart problem with your and are you on regular visits with your cardiologist?
Yeah. So sometimes, doctor, my blood pressure become high. So it's not that much high, and I don't need a medication for this.
Okay. Can I know when did you have your last echo done, Sarah?
It was last month.
Okay. Was everything told to be fine? Was the status told to be good?
Yes, every now and then I'm having my echoes, and my cardiologist told me that it's okay.
Okay. Happy to hear that, Sarah. Sarah, any other medication are you using? Other than, are you using any medicines for hypertension?
No, doctor, I'm having sometimes high blood pressure, but I'm not using any medication. Do I need to have a medication for it?
Yeah, Sarah, if your BP is not, blood pressure is not controlled, then you will have to use. If it is under control, it is not compulsory that you have to use. Anyway, now we will be reviewing your about that with the cardiologist once again.
So
And
he will be the one to prescribe medication for me for the blood pressure?
yes, Sarah, but there will be a group of specialist doctors. Since your pregnancy is a high risk pregnancy, it will be managed by a joint team of doctors, what we call as multidisciplinary team, which includes cardiologist, obstetrician, and also physician and anesthetist, who all will be will sit together and decide a management plan for you. So the medication, if it is required, which is safe in pregnancy only, will be given. Okay, Sarah?
Okay, doctor.
Okay. Sarah, can you tell me whether you have any breathlessness after doing a little work, or are you able to cope with your normal routine work?
Yeah. It's while I'm doing my routine work, I don't have any problem. It's only when I'm climbing stairs or I walk very fast, I feel some breathlessness.
Okay. Okay, Sarah. Okay. And did you have any other surgeries in your tummy or down from below or anywhere?
No, never.
Okay. Are you regular on your smears, Sarah?
Yeah, I have. Actually, I not yet start my smear. Somebody told me that it should be started at 25 years of age.
Yeah, sorry. And did you have your HPV vaccine done?
They asked me, but I refuse. I don't want to take this vaccine.
Okay. Okay, and you have just told me that you have other family members who are affected with the same problem, isn't it?
Yes. My maternal aunt and one of my sister also.
Okay. Actually, Sarah, this Marfan syndrome, it comes in families, and it is a dominant condition, what we say. So it will be expressed even if one genetic material from one of the parents also comes.
So, doctor,
One of the affected
sorry to
parent.
interrupt you, that my baby can have also this problem?
Yeah, that's what I'm going to tell Sarah. That there are chances that your baby may also get it.
Oh, okay. So, what are
Uh,
the chances?
it is 1 in 4, Sarah,
1 in
because
4?
1 in 4, or it may be even 1 in 2. Actually, to tell you exactly, it is a dominant gene. The affected gene is a dominant one. So even if one of the parent carries the gene, there are chances for the baby getting it. If the genetic material in you carries both the genes as affected ones, then there are chances of 1 in 2 babies having the affected 1 in 2 babies having affected. And if you have only one gene, then it will be 1 in 4, the chance will be. Anyway, this will be discussed with you in detail by the genetic counselor whom I will be referring you to.
Oh,
Okay,
okay.
Sarah?
Yes, doctor.
And we'll also have uh, detailed close monitoring throughout your pregnancy to see if your baby is affected and how is the baby doing during the pregnancy. Okay, Sarah?
Yeah, yeah.
Okay.
So doctor, can my condition become worse during pregnancy? The pregnancy has any effect
Yeah.
on my condition?
Yes, Sarah. I'm sorry to say that, but that's what there are little chances that you may have worsening of the heart condition, because in pregnancy the volume, overall blood volume will be increased, and there will be more strain over your heart. So as in the condition you have, that is Marfan syndrome, the aorta which supplies the blood will be having the problem. So you may have aggravation of the hypertension, and even there are more chances of you having hypertensive complication, what we call as preeclampsia. And there are also
So
even chances that
preeclampsia,
aorta.
doctor, is it high, due to high blood pressure? So I can have high blood pressure. My blood pressure can deteriorate, you mean?
Yeah, there are chances for that, Sarah. And also even the aorta, we call a condition called aortic dissection. I don't want to make you tense because of all this, but
No,
I'm
doctor,
just
I
telling.
heard about this condition because I know that I'm
Okay.
going to my cardiologist every now and then. He's checking my aorta diameter, and he's always telling me it is okay. So is there a possibility that during pregnancy it can become worse?
Yes, yes, Sarah. There are a little chance. There is a little chance for that. Uh, so you have to be on regular follow during the throughout your pregnancy and you have to be booked in a obstetric unit with facilities for a cardiology specialty within the hospital. And in your antenatal period, we'll be closely monitoring monthly or once in each trimester. We'll do your echo, and if any worsening of the condition, we'll do the monitoring more closely. These all medical management will be taken care of along by the cardiologist in the multidisciplinary team. And coming to the obstetric part, we'll be doing the now, since you are 8 weeks, we'll do a booking scan for you, dating scan for you. And Sarah, actually, I missed it. Are your cycles regular?
Yes, it is regular.
We'll do a dating scan for you.
Yeah.
Then we'll do an NT scan between 11 to 14 weeks, and after
Okay.
that, and you will have to be started on folic acid tablet now. Are you already on any medication for
Yeah,
the?
I started folic acid actually. Actually,
Okay,
I'm not
very
on
good.
my blood pressure, and I'm wondering if I need my for blood pressure, for high blood pressure. I don't know, but yes, I am on folic acid.
Okay, I'll check the blood pressure now, and based on the, and we'll have 2 3 recordings, and based on that we can decide. In the meantime, we will be having a visit with the cardiologist and the physician also, who will be also deciding about the medication to be given. I
Your
will
10 minutes
write
actually
the letter
finished.
to.
It's actually 11 minutes, but okay, finish, no problem.
Okay. And we'll be doing a detailed anomaly scan in the mid trimester around 20 weeks, and then we'll be monitoring you in the obstetric unit closely. Whenever you have any increase of breathlessness and any urinary tract symptoms or any edema of the feet, you have to immediately review in the hospital.
So, what are
And
the red flag signs and symptoms that she need to report?
red flag.
Mhm.
Any breathlessness chest pain,
So what are the risks for her?
aortic
It's like
dissection.
sudden shooting pain, or retrosternal pain.
Yeah, which is aortic rupture after aortic dilatation or aortic dissection, you can say. Aortic dissection, and which can ultimately lead to aortic, and she can collapse, she can syncope. So before this, she will feel that pain, interscapular pain, and her
Okay.
blood pressure can shoot. Signs and symptoms of preeclampsia also needs to be discussed with her.
Okay.
So these are the two safety points actually that we need to discuss with her. We have to tell her about her red flag sign and symptoms. So to tell you the truth, overall you finish only 1 minute more maybe you took, but at the end while you are finishing, don't ever forget about the patient information leaflets, advice to come back and follow up with her, and to refer to that. So what are the safety points do you think that are important in this station? Safety points.
Uh, to tell about the red flag signs and telling the importance of uh, genetic counseling, telling the baby risk of baby getting affected. Drug allergies actually I forgot.
So generally, as I said in the last station, what are the general safety points in all stations?
Drug allergies.
Yeah. Referral to fetal maternal,
NDT,
especially because she is high risk,
yes, ma'am.
and not only to FMM but as a multidisciplinary team, care as a multidisciplinary team, to inform her about the
place of delivery.
Yeah, about the sign and symptoms, red flag sign and symptoms. What if this same patient is on losartan? What you will do? This in the real exam, she was on losartan. What is
Then we have to
losartan?
stop ARB.
Yes, this is ARB.
We have to ask her to stop immediately. As it
You will ask
has,
her to stop immediately, or you will refer her to the or have urgent
her
appointment
to the
with her
urgent
cardiologist, and
appointment.
he will be the one to change it.
Okay. Okay.
Excuse me, doctor. Here we can discuss with the patient about termination of pregnancy also.
Yeah, you can discuss about termination if this is a unplanned pregnancy, which she is having unplanned pregnancy, but this pregnancy is welcomed by her and her partner. That's why I was kind of hesitating not to talk about termination. But if it is unplanned pregnancy, then it is written in the article to talk about the option of termination of pregnancy. Of course, this is one of the option. But when she said this pregnancy is very welcome, then you can say that yes, we have to offer you anti-scan and anomaly scan, and we might need to do some invasive test for you if we find that there is risk to your baby, which carries a small risk around 1 in 100 or 2 in 100 risk of your baby having miscarried, being
Same
miscarried.
disease, yeah. Okay.
At that
Okay.
time, he will decline. Actually, she very much want this pregnancy. At this time, that I don't want any invasive testing. But this is an important point to point out, that she need anti-scan, she need maybe NIPT if it is available, or the anti-scan and the screening and the anomaly scan. And because anyway there is a 50% risk or 1 and 2 risk of her baby.
Ma'am,
You didn't ask
she
about the partner
was like
status.
yes, ma'am, but I was like, if it was positive, she would have told. How can we know? Okay. Because you have told already about family history. If husband is
Yeah.
also positive, maybe informed. I thought I should have asked. Okay.
Yeah, so especially for partner, it is better to ask especially. because
Yes,
the outcome depends upon the status of partner. Yes, it is important to ask about family. Family history is important, but it is always better to ask about the partner status so that you can give the correct answer. What if the partner is also having family history, for example, of Marfan syndrome, and he
so
is a
if
carrier?
only family history, there will not be any risk. If partner is having Marfan syndrome, then maybe three in four, or all the babies may be affected based on if he is heterozygous or
Yeah, if
homozygous.
he is also Marfan's, because it is autosomal dominant, if he is also Marfan's, then most probably all the babies will be affected.
Yes.
But you rightly refer her to genetist counseling.
Okay.
Genetic counseling is very important for her.
Okay.
It is part of the multidisciplinary team.
Okay, ma'am.
And yes, she is 8 weeks and of pregnancy. Otherwise, you could have offered her pre-implantation genetic diagnosis, but she is already. Yeah. So what about she has 50% risk, and she want to know the same patient. She want to know that the baby got the disease or not. So what you will offer her? Yes, you will offer her NT scans, and this is for
NIPT.
this is all for not for Marfan syndrome.
Cell-free fetal DNA, is that
Is
available
also,
for
I
Marfan?
think it's not for Marfan syndrome.
Okay. Then invasive monitoring in
No,
amniocentesis.
only fetal echo. Only fetal echo we can do it, or it's a
Amniocentesis.
dominant.
The only thing which will tell you by for sure is by
Fish.
invasive testing. Which she is still away. She is 8 weeks only. The chronic villus sampling can be offered from 11 plus and amniocentesis from 15 plus.
Okay. And anything more to be added in the antenatal monitoring
Yes.
and in
Yeah, because you didn't mention about the teenage pregnancy. So this half of the question was about Marfan syndrome, and half of the question was about teenage pregnancy.
yeah, I noticed, madam, but where and when to ask, I was not.
So how you address a teenage pregnancy, generally speaking? What are the questions you need to ask the patient once you see that she is a teenager? What are the questions?
If she is with a regular partner, like whom she is living with, and while
Okay.
speaking to her, we'll be assessing her competence, and is she willing for continuation? What's the age of the partner?
You mean the mental competency? You mean Fraser? But she is 19 years old. She is an adult by definition, but she's just a teenager. So what are the teenager issues?
Aggressive behavior, smoking.
Yeah, so social history. So what you will ask in social history?
The smoking, alcohol, and recreational drugs, and environment
About
at home,
multiple partners.
any domestic violence.
Yes.
About sexual
So
multiple partners.
yeah, so this is a very, because she already said that my partner is very happy and welcome this pregnancy. So you can ask that, are you in a stable relationship? This you can ask. So she will tell you. So you will have an idea. If she will say, no, I just changed my partner, you will have an idea, right? But once she said that, you can ask a question that, are you in a stable relationship with your partner? So that you know that this pregnancy will be safeguarded and there are no safeguarding issues for the child also, unborn child.
Okay.
So yeah, social history is drug, history of alcohol, history of smoking, how she's supporting her. She's a student, she's still studying, or
Yeah,
she's
support.
working. Yeah, who is supporting her? Is she living with her parents, or is she living with her partner? Is her partner supporting her? These are the issues of teenage. And she understands what is Marfan syndrome, what is her background knowledge, which you already asked, I think.
Yes, ma'am. Okay, ma'am.
Okay, so what about she's already pregnant, and what else you can tell her the effect on pregnancy? What can Marfan syndrome, what is the manifestation of Marfan syndrome?
Hypermobile joints
Yeah,
and
so you should ask her
cataracts.
about her joints. Do you have pain in your joints? How is your heart? You already asked her about the echo done last month, which was normal. It means that her aortic dilatation is under control, is less than 4 centimeter. Ask her about her eyes, because it can cause dislocation of lens in the eyes.
Yes, ma'am.
And she can go on and develop hypertension, and hypertension needs to be treated aggressively. So you might tell her that if you are having high blood pressure every now and then I recommend you to go back to your cardiologist, and maybe he will start uh, antihypertensive for you, because it is recommended to start beta blocker if she is not yet on. Because this patient in the real scenario is already on losartan, and you should know what is losartan, ARB. Then you have to tell her that I need you to refer you to your cardiac doctor, so that he will change your medicine. Because what you will tell her about ARB, what are the effects on the baby?
IUD or oligohydramnias.
Yes, it is mainly affecting on the renal system. Did you ask about folic acid, if she is on folic acid or not?
Yes, ma'am. You told already she's taking.
Okay. Yes. I remember now. Yes. Yeah. So these are the risks that can happen to her. And every now, so what is the monitoring that needs to be done? Regular blood pressure checks, regular echos, multidisciplinary team assessment, and you have to tell her about the red flag sign and symptoms, and what you will tell her about the mode of delivery. And of course, you have to tell her about first trimester, second trimester, and third trimester, because you are going uh, to check the fetal growth and the NT scan and the anomaly scan, including the fetal echo.
Okay.
And what about the mode of delivery, time of delivery, and place of delivery? It's of course obstetric unit, place of delivery. You already refer her to fetal-maternal and to cardiologist. And if she has any joint problem, or accordingly, you will refer her. And mode of delivery, can she go up to, depending upon her condition of her heart.
In the late trimester.
What is the indication for cesarean section in this patient?
She had a history of any aortic dissection or operated for aortic dissection. She has to go or aortic root dilatation more than 4 centimeters.
Look
She
at
has to
this
go for cesarean.
cardiac indications for cesarean section. Root dilatation more than 4 centimeter, aortic dissection or aneurysm, even if she has aneurysm. Of course, because it can rupture during labor. And you ask her about her symptoms. So what do you think, which class of New York Heart Association she is?
Class 2.
So while she is walking routinely, on a surface, she's not having any problem. But when she climbed the stairs, she has some shortness of breath. So what is it?
It is more than routine work, so class 2 I thought. Like if it is exercise or training, it is 1. 2 more than routine work, 3 even on routine work, and 4 even at rest.
Yeah,
That's what
you are
I
right.
remember.
You are right. And what about aspirin? Should she take aspirin or not?
She's at risk of preeclampsia, so at 12 weeks we'll start her on aspirin. But
did you mention?
No, ma'am, I forgot.
Are in the preeclampsia guideline, I forget what is the indication. Is this cardiac condition is one of the indication to start aspirin?
No, ma'am, there it is not given.
So, so why we should start? Unless she is hypertensive, because in the first scenario I told you that she is having just mild hypertension, she didn't need, but in the other scenario she was hypertensive, chronic hypertension may be an indication.
Maybe it is an indication, chronic hypertension.
And the risk assessment for venous thromboembolism, never ever forget.
Yeah, you told now itself. Okay, ma'am.
Okay.
Yeah.
And
How
what
was the
about
overall?
the overall? You covered most of the points, to tell you the truth. I don't know if you remember Marfan syndrome or not, but you cover and you managed to, but at least you know that it is autosomal dominant, but you know that losartan is ARB, and you know the multidisciplinary team, and you know that she need the assessment for echo, for fetal echos. So but because you did not mention and you missed teenage pregnancy, which carries maybe almost half of the points. So whenever you are writing bullet points, you have to write issues. What are the issues? If I ask you to go back and write bullet points, let me. Okay, no, not this one. Yeah. So what you will write your bullet points in it. What are the things you want to say inside? Your bullet points should be.
So, in history, as she is Marfan's, I want to ask about heart-related problem complaints, and
You
in
will learn
family
about
history and
general history. She's 8 weeks pregnant. She has any nausea, vomiting. She has any abdominal cramps, vaginal bleeding. So these general things until 8 weeks of pregnancy, you can ask what is happening. So you can ask about these also. Yeah, okay, just a small point. Yeah, go on, continue, please.
about the husband, if he is also having any Marfan syndrome.
Yeah, you can ask this.
Regarding
Yes,
the social history and
social history
stable
is important.
partner.
Yeah. Should you ask about other, should you follow the history format, like history of presenting complaint, past history, because of Marfan syndrome, what are the things that you should know that can be affected? You can ask about it. And in her family, when she mentioned that syndrome, you should immediately ask how they are doing. Do they have any problem?
Okay.
And if they have any problem, just show some empathy.
Yes, ma'am.
Okay. And
Then regarding management, MDT involvement.
regarding management, yes. So after the history of history of presenting complaint, past history, in gynae history, like you ask about a smear history, and if this is a planned or unplanned pregnancy, how is a partner? This is all is good, and then family history. You ask medication history, history of allergy always. Ask about history of allergy always in every station. And then management, because she's 8 weeks, you have to organize whenever you start management, you divide it into multidisciplinary team, first of all, and then first trimester, second trimester, third trimester, intrapartum, and postpartum. So in your bullet points, you should write in issues. What are her issues? She is a teenage pregnancy. She has Marfan syndrome. So these are 2 issues. So how you are going to deal with teenage pregnancy, there is no need to ask. You should know that there are certain things in history that you should ask, and there is management, like she might be having nutritional deficiencies. So you ask about her diet, and maybe you need to refer to nutritionist to make sure that she knows how to take a balanced diet. This is her first pregnancy and she's teenage. Maybe she's going to have nutritional deficiency. And if she need any support services, you need to refer her to support services. If she has housing issues, you need to refer her to support services. If her whatever she will tell you, she needs support. She need nutritional to refer to the nutritionist, because she need to be counseled about the healthy and prenatal vitamins should be advised for her, because she's a teenager. And if she is having any smoking, drugs, alcohol, depression, all these issues, domestic violence need to rule out also. First, you no need to write. You should know how to manage a teenage pregnancy. By the way, there is a TOG article about teenage pregnancy. And then the other thing, you will write Marfan syndrome. So what are the questions that you need to write? History of Marfan syndrome. Just write a bullet point that you will ask inside history of Marfan syndrome. And what do you mean by history of Marfan syndrome? The severity of her condition, what treatment she is on, what other members in the family, and how she is doing. She is following with cardiologist. What is her last echo? So how she is doing with her heart condition. Is she having hypertension, hypertension, and what medication she is on for hypertension? So what about the stage of she can go and deliver vaginally or not?
If her cardiac status is tolerable when done near term, then she can go for vaginal
Someone
delivery.
told me the New York Heart Association class 3 and 4 needs cesarean section.
Yes, ma'am. She's class 2.
Yeah, for me, she is class 2. Yeah, in UK there is a Marfan trust. That is true. And what about what you will tell her about? Okay, place of delivery, obstetric unit for sure, consultant-led unit. Time of delivery, it depends upon her condition and upon her baby's condition. But you can let her to term if everything is okay. And the indication of cesarean section, you can tell her that if the aortic root dilatation is more than 4 centimeter, this is the indication for cesarean section. And it depends upon the deterioration in her heart condition, like the class, you know. This might be another indication for cesarean section. Yeah, 19 is a teenage pregnancy. So what is the risk of mortality? If she asks you that, is there a risk that I might die during pregnancy?
Yeah,
What you
this
will do?
Yeah, there is a risk of 40% if more than 4 centimeter dilatation.
And if 40%, let me see.
I think
So,
10% if it is more than 4.
yeah. So the mortality rate is if aortic root is less than 4 centimeter is 1%, and if it is more than 4 centimeter, it is 25%. I just checked
And
it.
Dr. Samira, the risk will remain till 6 months after delivery.
Yeah, we need to mention her this.
40%. I think 40% for Eisenmenger syndrome. I think I confused.
Yes, assuming is 40%. That is true.
Sorry, I confused.
Yeah, it is 25%. Okay, so what about the postpartum? Talk about contraception, talk about her discharge. It depends upon her condition. Any patient who is a cardiac patient maybe need to stay more, generally speaking.
Risk of infection.
Risk of, you mean infective endocarditis? Is it is Marfan syndrome, if everything is okay, is one of the condition that she needs antibiotics for infective endocarditis? I don't think so.
No,
But is
no. It is no.
Yeah. So it is not one of the. So we will not talk about antibiotics for infective
It is, I
endocarditis.
think, in rheumatic heart disease and prosthetic valve, that risk of endocarditis.
Yeah, okay.
This patient can go as a contraception for DIMPA injection. It is safe for her, I think. Or
I think
Implanon.
all cardiac diseases, progesterone is generally speaking safe. Progesterone contraception.
Yeah.
These are all support groups. Yeah, this is class 2. So I think, what are the safety points, doctor? What are the safety points? As you said, allergy, referral to the consultant, and checking, informing about the red flag sign and symptoms, informing her about the place of delivery, that she should be a multidisciplinary care. I think this is the safety point, and the losartan, which it needs to be changed. It's a safety point actually. And her teenage pregnancy, if she's not concentrating, if we don't concentrate on it, then this might become a safety point as well. Okay, who want to do the next station?
Thank
Can
you.
talk. Thank you very much. You can do as much mistakes here, and I'm here to correct. And we are all actually, I'm getting a lot of information, mashallah, because you are going for exam, you are fresh. For me, I'm not reading like you are reading nowadays. So your mind is very fresh, and I'm getting a lot of, mashallah, information from all of you. All of you are, your knowledge is excellent. But what I'm here to see is how you are going to do your time management, and what are the points that needs to be covered. If you have not covered 100% of your knowledge, you can pass the station. But there are certain safety points. There is time management, and for example, you need to make your bullet points. If you miss that she's a teenage pregnancy and you need to talk about teenage pregnancy, then your chance of passing this station become less. So I'm here to see that if you are not missing these points actually. And then we have a very nice discussion about knowledge also, which will help us, the people who are going in revision. So who want to do the next station?
Can I do, Samira?
Yeah. Dr. Sonia, are you the one? You're talking? Are you
Yeah,
going
I
for
can do.
November?
Yeah, I am going to November.
Okay, I'm giving you a scenario.
Yeah.
And you have 2 minutes. Write very nice bullet points, please. And I will ask you what you have written.
Okay, Dr. Samira.
2 minutes now. Okay, doctor, are you ready?
Yeah, Dr. Samira.
Okay, so go inside.
Uh, Hello, I'm Dr. Sonia, one of the exam candidate, and I'm ready for the discussion.
Okay, doctor. So you have read the scenario, right? So I want to ask you a few questions. So what are the questions you will ask in history and how you are going to manage the first and second trimester of this patient?
So first of all, I will introduce myself to the patient and to the staff, and then since she is in the second stage, so I will ask the midwife to tell me about the brief history of the patient
Like what?
Regarding her antenatal history, that it was uneventful or there was any complication in her antenatal history. Was there any history of preeclampsia or abruptio placenta or any other problem? And then I would like to ask about the the labor, when it started. Was it a spontaneous labor or it was an induced labor? And since how long she what was the duration of the first stage of the labor, and then for how long she's been in the second stage of the labor, for how long, whether she has received any epidural, any painkiller, and then regarding her PV findings, what is the what is the effacement, what is the dilatation and station of the baby, and then I will I will put on the gloves. I will examine the patient, and I will I will ask the midwife to inform the consultant, since it's a high risk pregnancy as second baby is in the transverse lie. So to inform the consultant and to inform the neonatologist, two neonatologists, it's a twin pregnancy.
and
Yes.
also there should be 2 midwives available for the care of the baby. And I will make sure that the fetal heart is there for both the babies. If it is not if it's not been recorded properly, then I can do the fetal scalp electrode for the first twin and the CTG for the second baby to know the fetal heart rate.
So this is generally speaking what you will do when you will enter inside. Okay, good. So what further relevant information you want to know about this twin?
Yeah, since this is a dichorionic diamniotic twins, and the first twin is cephalic. So first, I want to know the weight of the twins. What is the weight and um,
Yes.
then the presentation I know that it's a first that it's a the second twin is in transfer. So
what else?
Um,
Okay.
The gestation age of the twin. Like, what is the gestation age?
Yeah, this is an important
And
question.
yeah, gestation age and the weight of the twins.
Yes. Okay. So generally speaking, so how you will conduct the delivery of these twins and how to prevent the complications?
Yeah, so first of all, I will make sure the fetal heart is there. Then I will make sure that IV line is there. The two cannulas are there, and I'll inform the theater. So because the second twin may need for the emergency CS, we may have to take her up for the emergency LSCS. So after keeping everything ready, I'll examine the patient. I will see what is the station of the first twin, and if the membranes are ruptured and it's a cephalic, so first twin and if she's getting good contraction, then it's fine. If she's getting 3 to 4 contractions in 10 minutes, if not, then I can start the oxytocin drip to get the good contractions, and then I will deliver the first twin in the usual manner. And I'll hand over the first twin to the neonatologist, and I will clamp the cord and label it as a first twin, and I'll take the sample for the baby. And after the delivery of the first twin, I'll confirm the position of the second twin by per abdomen examination and by CTG, and also the ultrasound machine should be there, so that I'll confirm the position of the second twin. Because in around 20% of the cases, the position of the second twin can change spontaneously to the cephalic. But if it still transfers position, then there are 3 methods to deliver the baby. The first is that I can try the external cephalic version. So I'll tell the midwife to stop the oxytocin. So there is a period of an inertia after the delivery of the first baby. So in that period, I can try for the external cephalic version if I can convert that position to the cephalic. If it's not possible, then if it's not possible, then I can try for the internal podalic version. In that case, it ideally it should be done in the theater, internal podalic version.
Do you want to rupture the
In
membrane, doctor, before you
No,
will do this?
no. I will not rupture the membranes. I'll keep the membranes intact, as there is a high chance of the cord prolapse in the transverse twin. So, if the external cephalic version is not successful, then I may shift the patient to the theater, and I'll inform my consultant to come there. And then in the theater, we can try for the internal podalic version. In that case, I will introduce my hand with the membranes intact. I'll hold the feet of the twin, and then I'll take the feet out, internal podalic version, and I'll take the feet out with the membranes intact. Once the feet are down and that breech is engaged, then I will rupture the membranes, and then I'll deliver the baby as a twin.
Oh,
But
so actually this is a mannequin and this is a fetal doll in front of you. So can you show me how you can do external cephalic version?
Yeah, so in external cephalic version, first of all, I will confirm the position of the baby, where is the back of the baby and where are the limbs of the baby. Then I will with both the hands, I will hold both the poles of the baby, that one side the cephalic and other side the breech, and gently I will give the forward thrust to the baby. First, forward thrust of the baby, and gently, once the baby will come in the midline, then it's easy that the head will come down. So it should be done in a very gentle manner and slowly with the strokes.
Yeah.
Um,
So there is any pre-request for before you do the ECV? Do you want to check something?
Yeah, first I'll check the fetal heart rate, that it's fine before also and after also. Before external cephalic version and after external cephalic version, the membrane should be intact. It should not be ruptured, and there should not be any bleeding. There should not be any other complication like the deranged fetal heart, the fetal heart is disrupted, or the other that other indication for the cesarean is there, if like the mother is heavily bleeding, or there is the fetal heart is not good, or the membranes are ruptured, then I will not try for the external cephalic version.
Once you do
Then I
the
will.
ECV, then what? And now the head or the breech is down. So what you will do next after
So
success?
once the so once the head is down, then I'll tell one of the midwife to hold the head and guide it into the abdomen, and then I'll tell them to start the oxytocin drip to get the good contractions. Once the head is in the pelvis, then I'll rupture the membranes, and then I'll deliver the baby as you. I mean, as a cephalic and normal delivery, and then I'll hand over the baby to the neonatologist and clamp the cord, and
So
then
how
I'll
to manage the third stage?
Yeah, since this patient is at high risk of the postpartum hemorrhage, as she is twin delivery, so I'll do the active management of the third stage. And I'll give the uterotonics, and it will be 10 units of the oxytocin intramuscularly, and then I'll wait for the separation of the placental sign, that is the lengthening of the cord, the gush of the blood, and the placenta and the bulge downwards, and then I'll remove the placenta and membranes by control cord traction. And then after the removal of the placenta, I'll check for any tears, any vaginal or the cervical tear, and then I'll check. I'll see for the estimated blood loss, and if any tears will be there, then I'll suture them, and then I'll do the instrument and the swab count. Then after that, I'll debrief the mother regarding what happened.
Actually, this is very important. So your 10 minutes finished, but you should complete what you will tell the mother.
Yeah, so I'll debrief the mother that she had like this, the first twin delivered normally, and second twin we had to do certain maneuvers and delivered it, and now the babies, they are with the neonatologist, and they will update her about the condition of the babies. And then I will mm, uh,
That's it.
I think there is no need for incident reporting, yeah, in this case.
No,
Yeah.
just
Yeah,
need
yeah.
good documentation and debriefing to the mother, because she must be twin delivery itself, especially you are doing maneuvers, you are trying
Yeah.
ECV, you are trying internal podalic version, then then she need debriefing for sure. Yeah. So
Yeah.
so overall, you managed to finish in time almost. Only
Yeah.
1 or 2 minutes you took more. So almost
Mm-hmm.
you managed to. So you need more practice so that you can manage to finish in time, and ask only relevant history. In history, you ask when you enter the labor room and you find that the patient is fully dilated. Now tell me again, what are the 4 points you will ask the patient and the midwife? What you will ask the
So
patient,
I'll
by the
ask.
way? You will introduce yourself to the patient, and
Yeah.
then
Yeah.
what you will ask her
Then
next?
I'll ask regarding
She has
the
only one
gestation and
concern. So you you reassure her that
okay.
everything looks okay. Your baby, your CTGs, both of them are doing fine, and I'm here to help you to deliver. And not only reassure her, you have to ask her something about her pain. If she's in pain, and you have to ask the midwife what pain management you are doing for maybe she is in epidural, so that how you can do internal pedalic version and or even ECV if she is in pain.
Yeah.
Mm. And okay, so you have to make sure, first of all, she is in adequate analgesia, she is hydrated well. These are the general points. This is not specific to twins. These are the
Yeah.
general points. Introduce yourself, reassure the patient, ask her about pain, her pain. Ask the midwife about what she's taking for pain, and about the hydration level. So these are the, so what are the specific point for this patient that you will ask?
For the gestation age of the patient
Yeah, it is
and
because it is not mentioned here. Yeah,
yeah.
maybe she is preterm.
Yeah.
Okay.
So then
You have to check her antenatal care plan, that
yeah.
if there is anything special written in her in this plan. If she's going
Yes.
for a spontaneous a delivery, so is it in the plan or not? Or she just came
Yeah.
fully dilated?
Yeah. Okay.
So you will check her care plan. You like to, because she's twin, it is better to check what's her gestational age, what is the weight of the baby, because if the second baby there is discordant, I think if there is one FGR baby, she needs to be taken for cesarean section. As there are some points in delivery of the twins that you need to see, the weight of the baby is discordant, weight discordance, and where is the placenta. The second twin can turn, so it is not an indication for cesarean section. She can have a spontaneous vaginal delivery if first is cephalic. And there is one thing which was coming to my mind. So if this is a spontaneous, maybe it is important to ask if this is a spontaneous pregnancy or this is IVF pregnancy, so that we can be more cautious. Maybe she is
Yeah.
waiting for this pregnancy for 10 years or 6-7 years, and now she has this. So maybe it is better to ask if this is a spontaneous twin or this is a IVF twin, and her antenatal care plan. So ask the midwife how she was doing in her labor. This is spontaneously she came in labor, or you induced labor. This is
Yeah.
important thing to ask. And then how she is doing the CTGs, both of them, for the labor, and how long she is in second stage.
Yeah.
When last time she was being examined, and she was found to be fully dilated. And I think these are the important things that need to be asked from the midwife. And if she has any medical comorbidity together with the twins.
Yeah.
course, you will not ask social history here. You will not ask family history. You will not ask how was your smears, for sure. You will
Yeah.
only ask the targeted history. What is important here now, right now, and the position of the placenta. Then the second question was that how you are going to conduct the delivery. So you have to say that because she is multiple pregnancy, we have to secure the IV access. Now there is one thing that for some reason, for normal spontaneous vaginal deliveries in our hospitals, we keep IV access for all patients, whoever comes in labor, all low risk patients. But there, for low risk patients, they don't maintain the IV access. But for this patient especially, you have to make sure that she's having a IV access. She have group and save, because she might have PPH and you might need blood for her. And
Yeah.
and then you can say that I will deliver the first, I will check how she's contracting, and if her contractions are fading away, I want to make sure that I will check the bicep score, where the head is, especially if the CTGs of both are reactive. Then I might think of starting oxytocin. Make sure that she has a risk of uterine rupture, so you involve your consultant. It's a safety point.
Okay.
And then you said that I will deliver the first twin like any singleton pregnancy. And the second one, as you said, the steps that I will ask an assistant and a midwife. I will call the neonatologist to be ready, because there need to be two pediatricians who should be ready to receive two babies. And then after delivery, I will wait for some time. I will see if she's contracting or not. If she's not contracting, I will start the syntosnone. I will not rupture the membrane until, because she is already transverse. So I will either go for ECV or internal podalic version, but initially for ECV. And I want anesthetic to be around. I want pediatrician to be around. I will call my consultant. It's a safety point. And then you keep on monitoring the baby while you are doing the ECV. And once they will say, show me the technique of ECV, it came in real exam, you should practice or to watch video at least how to do the ECV, because you need to demonstrate it over there.
Okay.
And then also in real exam, they ask about how to conduct internal podalic version. So you have to say, it's a safety point, that I'll call my consultant.
Yeah.
But you have to show the technique of internal podalic version on a pelvic model. And then you go on and talk about managing third stage, because why they ask about third stage, because she is high risk of PPH. That's why. Any patient who is high risk of PPH, is it worth to give her only syntocinon, or should you give her symptomatrine after making sure that she's not hypertensive? Should you give her
they
Synto
said
only or symptomatrine?
no. If she is at, they say that very high risk of PPH. I mean,
I think we should not give
symptomatrine.
symptomatrine, doctor.
Yeah, it
We
is
should not give
if PPH.
symptomatrine.
Uh,
Even
Actually,
if she's
PPH
high
till
risk,
the
means
level of
we are giving
500
her
ml.
10 units. Yeah.
PPH, they say PPH till the level of 500 ml, it is controlled equally by both the drugs, by oxytocin and by symptomatrine. But symptomatrine is having more side effects. So we should give
Yeah.
only oxytocin.
Yeah, and that
But if
PPH
there
guideline
is,
is saying if you give only Synto, it is controlling 60% of PPH.
yeah. But if she has more than 500 ml, then we should give symptomatrine.
You are talking about treatment, management of PPH. I'm talking about prophylaxis, because of the history
Yeah,
of.
Yeah,
I think
prophylaxis they don't
prophylaxis
advise.
only 10
They say,
units.
yeah, only oxytocin 10 units.
Yeah, because PPH guideline saying same.
Yeah.
What about if patient has history of PPH? You will also give only 10 units prophylaxis?
Yeah, if she have history of PPH and her this current pregnancy, her hemoglobin is well okay. Her we can have the group and safe cross match ready in hand. In case she bleed, then we can I think give extra measures.
What about if she has previous, she's priming this scenario, but any patient who has previous history of PPH?
She I think can go for active management of third stage. But I'm not sure that we should give her IV drip Sinto in as per NICE guidelines or Green Top guidelines.
In PPH
Dr.
guideline,
Samira?
only mentioned Sinto
Dr.
for
Dr. Samira,
prophylaxis. Yeah.
methogen should only
Yes,
be given
Rubin.
if there is PPH.
You mean
Prophylactically should not be given. If there is PPH, then it's in the algorithm, but not prophylactically.
I read somewhere and I'm always confused that there are some conditions in which we can give symptometrin as prophylaxis. Do you remember what is this indication?
No. I think only PPH. If she's having PPH, then we can start as a pharmacological measures.
So this can be like a
Doctor?
brainstorming question to look.
Doctor,
I don't know, Miss. Don't remember as much as no.
Yeah.
Yeah,
So
because
okay,
I think new guidelines are that only we'll give only oxytocin.
Yeah, the
So if it is
PPH
in the
guideline 2017 came. It is
yes.
saying only oxytocin.
Okay, if it means generally speaking, they generalize to all patients, even if high risk.
Yeah, it is nowhere written that previous history of PPH. Then we should consider symptometrin also.
Doctor,
Okay.
Doctor, in the new multiple pregnancy guideline, it is mentioned that if there is increased risk of PPH, then you can give additional uterotonics. It is given in new multiple pregnancy guideline.
Is it prophylactic or once she has PPH?
No, it's written that if there is additional risk of PPH, then you can give additional this thing,
So
uterotonics.
additional means symptometrin. This is additional.
Apart from the usual 5 units in normal delivery, or 10 units in normal delivery, you can give additional ones if you suspect that she's at high risk for PPH.
Yeah, this is somewhere is I don't know from where I read, but
In,
and why don't know
in the
I don't know why
multiple
it's coming to my
pregnancy new
mind.
guideline, which has been issued this year, it has been mentioned in the management, like you have to go for the active management of second stage. And in the same situation, it is written that if there are additional risk factors for increased risk of PPH, you can go for additional uterotonics.
Okay, we can go through this is a brainstorming question, takeaway message that we can review the new NICE, as you mentioned, the new NICE guideline for multiple which just came in
Sorry,
September.
doctor, but I think infusion, in case if there is a patient has a risk of postpartum hemorrhage, we can use infusion for her, not
But it is written like she is at risk. Means if she is having risk,
She's
means
not
maybe
right
she's
right
bleeding
now.
or
She is not bleeding, but she is high
yeah.
risk for PPH. This is what my question is, because I read somewhere that we can give symptometrin if the patient is high risk
It is
for.
written in PPH guideline, doctor. It's written if increased risk of hemorrhage, you can give ergometrin, oxytocin. It reduce 500 to 1000 ml. In PPH, it's written.
Dr. Samira, it is written in the multiple pregnancy guideline that if the patient has additional risk apart from twins and triplets, then you have to give, like twins and triplets, they have written apart from twins and triplets, there is additional risk, then you give additional uterotonic. Like twins and triplets, they have considered like usual management. And if additional risk apart from the twins and triplets, give this. They have written like
This is
this.
very
So
good
that
information.
interprets that twins and triplets itself is not additional factor. But if apart from that they have additional risk factors, then we can consider that
Maybe
additional
in
uterotonic.
PPH guideline they mentioned the risk factors. for the...
Yes, doctor, in PPH it is written, in PPH guideline it's written clearly, if increased risk of hemorrhage, give ergometrin and oxytocin, it reduce blood 500 to 1000 ml. It's written very clearly in PPH 2016.
So generally speaking, if she is high risk for PPH, like for me, twins is high risk for PPH, but it is written in the new NICE guideline, which is just came out in September 2019, that it should be an additional risk, not only twins. So it means that you go by...
Yeah, so it should be an additional risk means like previous history.
Yeah, previous history, or what can be delay in the second stage, delay in the first. There can be any additional risk.
Yeah.
She is on
Or
syndrocinone.
maybe anemia also.
Yeah, there are many risk factors for PPH. It is in the PPH guidelines. So any additional risk factor, which can happen most probably in twins, delays can happen. She might be on syndrocinone. Any additional risk factor can easily happen in twins. So what we know that only twins, if everything is perfect and going on well, then there is no need. But I think if the patient is second baby is transverse and you are doing maneuvers, and there is most probably a delay in delivery of the second twin, that most probably put her in high risk for PPH. Okay, so what are the safety points, doctor?
Safety points will be first involvement of all the consultant and the neonatologist, and involvement of the theater, and then to start the IV line to keep the patient ready for the for any upcoming complication, and then maybe to stop oxytocin after the delivery of the first baby till
Because it is
the
transfers to stop oxytocin. Maybe you didn't mention it, but it's a safety point, yes. And if
so
if you want to do ECV and she's contracting, what you will do?
then I will not do ECV, because if contracting means that is also a relative contraindication for the ECV.
Yes. Can you do
Then
internal
if
podalic
oxytocin
version?
is on, then I will we can do in that time period. If oxytocin is on, then we will stop that, and in between the contractions we can try. But if she is contracting every 2 minutes or 3 minutes, then I think we should take her directly for the cesarean.
You will not try terbutaline 0.25 mics? You will try or not?
I think, I will try, but I will weigh the benefits and the risk, because with the terbutaline sometimes there is increased risk of the postpartum hemorrhage also. So if she
That's
is not at high risk of the postpartum hemorrhage and only twins, then I can try for the terbutaline and try for ECV. But if she is already at high risk of the postpartum hemorrhage, then it will add on to that. So then maybe I will not try.
Yeah, so no one will deduce your mark if you will say this, because you are actually a safe doctor. There is no black and white for the management of twins. It's not something straightforward. If you think that she is high risk for PPH and you know that terbutaline will increase her risk for PPH, then you might not want to go for it. This is your choice, and it's not written in the guideline that you can do this or you can not do this. So it
So this
just
patient
shows
we
that
can
you are
take for
safe.
cesarean section also.
Yes, this is one of the options. But here they are concentrating more on ECV. Even they bring the mannequin and they want you to show how to do the steps of the ECV and how to do the steps of internal podalic version. So it looks like that they are more interested in these maneuvers before they think about taking her for cesarean section. Of course, the last resort of everything is cesarean section.
Yeah.
And if the CTG is okay, then and you are able to, she's not contracting regularly, and the membrane is still intact, then you can think about ECV. So you have to always talk about the prerequisite for ECV or internal
Yeah.
portal version before you actually start showing the technique.
Mm-hmm. Okay.
Okay, who want to do the next one, the last one?
What is the topic, doctor?
No. So who has the courage without looking,
I'm
who can
ready
do
to
it?
do. I'm ready.
Dr. Dev, I think you have done one, right?
Yeah, I did.
Yeah. Anyone who is going for November and have not done a station? Dr. Rubina? You want to
Can
do it?
yeah, yes, I want. I don't know what would be the
You are
topic.
going, no,
Yeah,
I
I'm
will
going.
not.
I am going for exam.
So you are going for November exam. So any topic you can do, right?
I'll try my best.
Yeah, this is the thing. Okay, let me show you.
Doctor, my exam is on 4th of November. I will be on the first day, like first batch
I will
candidate.
also be
It
fourth.
will be okay.
I'll be also fourth.
You, Dr.
It
Rubina,
will
you
be
are
okay.
also 4?
Yeah, fourth.
Yeah. Me too.
So, yeah, so both of you can do a station, no problem. First, Dr. Rubina, let her do, and then you will do. No problem. So
Okay.
I'm giving you, Dr. Rubina, 2 minutes.
Okay. Okay, Dr. Samira. Hello.
Okay, you can enter. Your 2 minutes finished.
Okay, it's a structured Viva. Okay.
Yes.
Okay. I'm Dr. Rubina. I'm one of the candidates for the exam. I'm ready for the discussion.
Okay, have a seat, Dr. Rubina. So you have
Thank
read
you.
the scenario,
Yeah.
right? So I'm going to ask you 3 questions related to this. So what
Okay.
questions you will ask in history, and how you will manage her first and second trimester of pregnancy?
Okay. First, I'll introduce myself to the patient, and then I'll ask her about her current pregnancy. How many weeks is
Yes.
she, and how is her pregnancy going so far? Does she have any
Mhm.
nausea, vomiting in this pregnancy? And does she have any scan in this pregnancy? Has she done her booking bloods? And
Yes.
if she's 11 plus, then has she done the Down syndrome screening or not? Okay, so and also I'll ask her if she has taken preconceptional and post-conceptional folic acid supplementation.
Yes.
Has she started aspirin in from the 12th week of pregnancy or not? And she where is she following herself in the consultant-led unit or midwifery-led unit? And
Yes.
is there any complication so far in this pregnancy? And is this pregnancy multiple pregnancy or singleton pregnancy?
Good.
And then I'll ask her about the past previous pregnancy. What happened in the previous pregnancy? When did she develop the preeclampsia? In the last trimester or second trimester or last trimester? And how did she deliver? She delivered cesarean section, obviously. What was the indication of delivery by cesarean section, obstetrical indication, or maybe due to high blood pressure? And how was the recovery of the patient? Did she stay in the ICU? And or did she receive the magnesium sulfate? I'll ask her, did she receive any medication for the prevention of fits? And did she stay in the ICU for how many days she stayed in the hospital? And did she take any antihypertensive in the pregnancy and after the delivery? And when did she stop her antihypertensive medication? And did she have her postnatal visit at 6 weeks of pregnancy? And and also I'll ask her about her medical history, like if she's taking any medication, is she allergic to any medication, what's the blood group of the patient, and any medical or surgical history and the family history of concern, and social history, who she's living with, supported or not, her mental history, and history of smoking, alcohol, and recreational drug, and her blood group of the patient, and so first trimester she will start folic acid and aspirin, and from the second trimester she can have uterine artery Doppler ultrasound to see to assess the risk of preeclampsia in this pregnancy, because she had preeclampsia at 35 weeks of gestation, so 7 to 10% chance that she will have preeclampsia again in this pregnancy. So she will have close monitoring. She will have extra visits in the hospital, and for after 20 weeks of the gestation, we'll monitor her blood pressure at every visit and also urine protein at every visit. She will be managed in the consultant-led unit. Yes.
Yes.
You said
okay. So this is how you are going to manage her first and second trimester. Okay.
Yes.
So what about her? So now she has this same patient. She had uneventful pregnancy until 36 weeks. Then her blood pressure start to increase at 36 weeks of gestation with proteinuria +1, and scan showed that the baby has oligohydramnios.
Okay.
But
Okay,
normal
now
Doppler. CTG is reactive.
Okay.
And
Blood
she
pressure,
is
how much?
asymptomatic. Her blood pressure is increasing from 110 to 80 at booking. It is increased to 140/90, but she is asymptomatic for preeclampsia. So how you are going to manage her?
Okay, now this is actually okay, because now blood pressure, the classification of preeclampsia is according to the blood pressure. With this scenario, 140/90 blood pressure, protein 1 plus, this is mild preeclampsia. But now we have two situations. Mother has mild preeclampsia, but the baby is IUGR. So we have to manage both of them together. So for the preeclampsia, mild preeclampsia, she can be managed as outpatient clinic, and we have to do her PET workup, including renal function test, liver function test, uric acid, urine for microalbumins, and clotting profile. If it's normal, we can repeat after a week. And we need to give her blood pressure monitoring. She can check her blood pressure alternately at home, and she can bring you the profile to check her blood pressure was okay. And because we need to keep the blood pressure as 135/85. This is the target blood pressure in the pregnancy. So then for the IUGR, because baby is small for gestational age, we need to confirm this is IUGR or small for gestational age. How much is the weight of the baby? And we have to see how much is the amount of Leica and umbilical artery Doppler, how is the pulsatility index and diastolic flow. If everything is going fine, she can be managed at like weekly ultrasound and weekly Doppler. If there is any derangement in the Doppler, then we have to like if absent, reduced, or absent or reduce or reverse, then we'll admit this patient. And if any complication, then we have to deliver this patient at 37 weeks of gestation. If there is IUGR and if there is any abnormality of the Doppler. And also if there is any abnormality in the blood pressure of the patient, if she is mild to moderate preeclampsia, then we'll admit this patient.
So doctor, if you're saying that if there's any complication, then we will deliver at 37. Otherwise, we can take her to term?
If the Leica volume is normal and if the umbilical artery Doppler is normal and the baby is growing, because we know it's SGA, we don't know it's IUGR yet. So we need to confirm that it's IUGR or not.
In preeclampsia patient, can we go more than 37 weeks?
If mild preeclampsia, I said 37 weeks, we'll deliver at 37 weeks.
Okay, fine. Okay, doctor. So what about now she's the same patient, her blood pressure increases and her obstetrician planned her for emergency cesarean section. But suddenly at 36 weeks. So suddenly she has acute abdominal pain with fresh vaginal bleeding and ultrasound confirm IUFD.
Okay.
So what is your management now?
She is now preeclampsia with IUFD. First, we need to counsel the patient. We have to be very empathetic with the patient. We have to tell the patient what has happened, and we'll tell her about the management plan and what we're going to do. And she is now is abdominal pain and IUFD. So this is a rupture. Now my further management will depend on the Bishop score of the patient. I'll do Bishop score of the patient if it's favorable, like she is in active labor, 5-6 centimeter dilatation, and I'm expecting that she can deliver soon. Then I will do ARM because the only indication for the ARM in IUFD is a rupture. So I can do ARM and deliver her. But if she's remote from the delivery, then to prevent the complication of preeclampsia and also to prevent the uterus covalier, we have to do cesarean section for her. And keeping in mind the risk of postpartum hemorrhage as well.
Yeah, depending upon her condition, upon her Bishop score, how she is progressing in labor, you will decide about her mode of delivery. And then after delivery, what you will do?
After delivery, because you said it's now also depend on the if it's moderate preeclampsia or severe preeclampsia. If this is severe preeclampsia, confirmed by the confirmed by the biochemical tests and also symptoms of the patient and blood pressure. Three things. Three things we have to combine, and then we'll decide if it's a severe preeclampsia. Then we have to give her magnesium sulfate as well for 24 hours post delivery. And maybe patient needs to be kept in the high dependency unit. And if the blood pressure is high, patient will also receive the IV antihypertensive like labetalol, which should also be done in the high dependency unit. And also we have to be careful about the PPH. This patient had APH, so she is more prone to have PPH as well. And this patient will need vigilant monitoring in HDU.
When she can be discharged?
Then depends on the situation, condition of the patient. If she recovers well from the HDU and she comes back to the ward, then on day 3 and 5, you'll check her blood pressure once daily, and then you will give her 2 weeks appointment with the 2 weeks appointment to, because maybe we started her on oral antihypertensive. So after 2 weeks, we'll reassess her to check if she needs antihypertensive or not. And then again at 6 weeks.
Yeah, that is true. Okay, thank you very much. Actually, you exactly on time, and you have said most of the points. This is actually looks like a very simple station, but people miss a lot of point. Um, there is a guideline, hypertensive in pregnancy, nice guideline. And we are not managing our preeclampsias according to this guideline. So this is the main reason that we get distracted, because our management, the frequency of monitoring is completely different what we are doing, what it is written there. And yes, we are giving antihypertensives, we are giving magnesium sulfate, but especially in the monitoring of the patient, the frequency of monitoring is a little bit different. And even in the postnatal period, the frequency is different. What we are doing and what is written there. That's why we get confused. But you managed to do it. You managed to finish, and you manage actually to cover most of the points, I must say. So it is a passing station for you.
Thank you. At least I passed in one station.
Yeah, you passed in practice stations. So most probably you will pass also. Inshallah, all of you will pass. So all of the people who have done the stations, believe me, they have done it very well. I cannot say any of them that there is any doubt that they will not pass. But
Oh, thank you so much.
maybe, yeah, all of them will
Yeah, we will
pass.
try our best.
There is 1 month remaining.
Thank you, Dr. Samira.
Yeah, Dr. Sunit, 1 month is still remaining. You still have to practice and try to finish in time. If you miss few points in knowledge, you can still pass the station. But don't ever miss the safety points and the main issues. So what is, doctor, do you think the main issue in this question? So that's why I'm concentrating on the bullet points. Please do not miss the main issue. So what is the main issue over here?
Main issue is she is a previous history of preeclampsia.
Yes. Second
And
yeah, we need to mention about the
this is a
recurrence risk. Yeah, that is true.
yeah, recurrence risk. Yes.
The
And need
recurrence
to
of
start
preeclampsia.
aspirin, and need to start aspirin from 12 weeks of gestation.
Yeah, that is true.
This is very
That is
important.
true. You already mentioned about it. The recurrence risk is 16%. Who is Dr. Momina? She is absolutely
not. After 35 weeks, I think it's not 16.
So what I read recently in the
Actually,
guidelines.
doctor, there is an updated guideline now in July 2019. It's changed many things like hypertension and severe hypertension. Now there is no mild, moderate, and severe. And about the treatment, they are starting the labetalol even at 140/90, and they are admitting if there is a maternal or fetal concern. As you say, there was a oligohydramnios, so this patient should be admitted, and even at
Should be
36
admitted.
weeks we need to
It's a safety point.
should be admitted. It is now the new guideline.
Only
There is a
oligo,
big box,
only oligo you cannot. Only oligo, if
but it is a
umbilical artery
maternal or
droplet is
fetal
normal.
concern written. If there is
Yeah,
a concern of maternal or fetal,
I
Not
will tell you
only
something. For me, preeclampsia needs to be admitted.
yeah, because preeclampsia is
yeah,
already proteinuria is there,
preeclampsia. She's having
and
proteinuria also.
yeah,
Not
so
because of oligohydramnios, because of preeclampsia,
yeah.
she needs to be
Yeah,
admitted.
but previous
Yeah.
guideline was telling preeclampsia 140/90 just admit and observe. But here
Yeah.
now new guideline saying 140/90 you have to start the labetalol, admit the patient. If there is a baby or maternal condition, any concerns, then you have to plan for the delivery according to the hematological and biochemical parameters.
Now, I want to ask you that there is not only hematological and biochemical and maternal sign and symptoms. There is one more thing to categorize this patient as severe preeclampsia. Can you tell me what is it?
No, actually, the blood pressure is the parameter.
Yeah, we know already blood pressure is the parameter. Biochemical symptoms are the parameter. Yes,
Yeah, with previous
biochemical.
history, she's a previous history.
If the patient is having growth restriction, she is IUGR.
Yeah, IUGR also, yes.
IUGR is a risk factor. If some patient with preeclampsia is having IUGR, it means she is having severe preeclampsia.
Yes, yes.
Yes, yes,
Because
she is at
IUGR
risk of
comes
preeclampsia. Yes, correct.
IUGR comes with definition of severe preeclampsia. If even the blood pressure is 140/90, but if there is IUGR, the definition becomes severe preeclampsia.
Yeah, that is true. This is what
Yeah,
I
because
want to
nowadays
mention here.
they remove the mild, moderate, and severe. Only hypertension and severe hypertension they have mentioned.
Yeah,
Okay.
in the preeclampsia, there is no mild, moderate, severe. If there is protein, there is protein. There is no quantification that mild or moderate. The quantification is not according to the blood pressure.
Okay, very good. Because in second question, she was her blood pressure was increasing. It was increasing to 140/90 from the baseline 110/80. So she is hypertensive. But once someone says she is having growth restriction or she is having oligo hydramnios, it means which categorize the patient automatically to severe preeclampsia. And now we will manage the patient. So it's a safety point to admit the patient.
Okay.
And manage accordingly. So what they decided,
Twice weekly Doppler and twice weekly PET workup. If she will be inpatient.
And she will be inpatient, yes. So monitoring of the patient, yes, monitoring
No,
of
no.
the
If she
patient
is
should be done.
inpatient and if she is having severe preeclampsia, it will be thrice a week
Not
management.
severe. 140/90 is not severe.
Yeah. 140/90. Yes, it's a twice weekly. Yeah, correct.
Yeah, we are confused. This is what I'm telling you, that we are confused in monitoring because we are not following in our hospitals this kind of monitoring.
Yeah, correct.
That is why. But we have to look at the new guideline for, as you said, July 2019 for the monitoring. Has they changed anything for monitoring or is the same?
Yeah, they change monitoring and they change for the postnatal treatment also.
Okay, good to know. So once the
And
examiner
the target blood pressure and the target blood pressure is now 135/85. This is the very new thing.
Yeah, you mentioned about this 135 and 85.
Yeah.
You mentioned it. Yeah.
It's in the new guideline actually.
Yes. So good to know this. When someone says she's planned for emergency cesarean section and then she has most probably abruptio, and then by ultrasound IUFT is confirmed, then you need to involve, because a condition, it's a safety point also, a condition that can kill a baby. It's a very well known saying that a condition that can kill a baby can kill the mother as well.
And
So
doctor,
you
one
need
more thing I want to ask you. In this new guideline, they have mentioned for women of the Black, African, or Caribbean family origin with the hypertension during the postnatal period, consider the antihypertensive treatment. Start with the nifedipine. Why like this? Nifedipine or amlodipine only for African and Caribbean?
Because African people are having high risk for this one. Maybe because this is the
Blood
reason.
pressure.
But why nifedipine?
Yeah, because they remove the labetalol already. Yes, methyl-dopa we are not giving in postnatal, but now the first line of treatment for these people,
I will tell you
nifedipine
something.
and then amlodipine.
It has been a question since long time that what is the
Yeah.
first choice postnatally? What is the first line of medication?
We used to give here like labetalol only we are giving because
Labetalol we can
methyl-dopa we
continue,
are.
right?
Yeah.
But in Africans, they want us to change it to nifedipine, right?
Nifedipine or
There must be
amlodipine.
some.
Yes.
There must be some reason why this ethnicity, especially, maybe they are not responding very well, and they are having refractory hypertension, and they are not responding well to labetalol. They have done some studies or something. There must be a reason
Okay.
behind
Maybe. Yeah, maybe.
it. So, what else do you think is the safety point?
She's one previous LSCS also, so we have to think about her previous
This
scar.
is another issue. So you need to ask about her antenatal sheet, and you need to see that what kind of scar she had. She's having a
And she's
transverse
bleeding with
scar.
abruption. Yeah, with abruption, we can give her option for vaginal delivery to go on or no.
Yeah, either you should allow her vaginal delivery or not. It all depends on her previous cesarean section. Maybe she was not in labor. They were not able. There is no lower segment. God knows, and what kind of scar she had. And maybe she had extensions, or maybe uterine rupture or anything. And you need to check her notes, previous notes, and her antenatal sheet. What is written in her plan? Because she is anyway. She now comes to you. Sorry, she comes to you in booking visit, so you need to check her previous history. So you need to write issues. The issues are: she has history of severe preeclampsia, she has FGR in previous pregnancy, she has a preterm cesarean section, and yeah, these are her issues actually. And then it's a progressive viva. Do you notice that it's a progressive viva? The examiner is progressing in her
What is
his
progressive viva, doctor?
Progressive viva, that he is asking now. She came to at booking, and now she is at 36 weeks of gestation. The third question
Okay,
is
so managing antenatal step by step. Okay.
step by step. So and then now she's planned that the third question, now she's planned for emergency cesarean section, and she has an abrupture IUFT. We call it progressive viva. You know that there are lay examiners now. Can anyone please give me input? Last exam there were lay examiners. So how you have to behave with the lay examiner? So you will enter inside, and the lay examiner is behaving like a simulated patient, right? So you need to greet him like a patient, and then treat him like a patient, and then later on he will become an examiner in the middle, and then he will start asking questions. This is my understanding?
No, Dr. Samira, I did RCOG course last month.
Okay.
There will be two examiners inside, three people inside, one patient, one examiner, and one layman examiner.
Okay.
So
But
a
I
layman
think
examiner, in
as
the
far
end, you
as
will
I
know that
know,
she was the layman examiner, and she will because she
yeah,
also scored me.
but lay examiners or real examiners, they both will not talk with us, right?
In structured viva, the examiner will talk, and the lay obviously the examiner will not talk. But obviously the lay examiner will come in the patient simulated viva. The examiner and both of them, they will not talk. You will have to talk to the patient, because I did RCOG course last month, and we had two
So I'm
stations for the
still
layman.
confused. So lay examiner, when you enter in lay examiner station, there are two examiners. One is the real
Yep.
examiner, and one is the lay examiner.
Yes.
And
One
the
is the
lay
real
examiner
examiner.
is behaving like a patient, right?
No. She's also sitting with the examiner, and she's just observing you.
Yeah, and I got to know that they are these stations are
Layman
the
examiner is silently observing and marking you if the marks are depends on if he likes your behavior with the
and
patient. He wants
I heard
you.
lay examiner stations are giving more marks.
Dr. Samira, actually the patient, the case was termination. The girl is asking for termination of pregnancy, and she had history of rape or something. So you have to be very empathetic. You have to counsel her and make rapport with her. And so I was just doing this, and in the end, I noticed that there was another lady sitting there, and in the end, she also gave me marks.
Oh, so there were three people.
Yes. This was in the RCOG course last month in Riyadh.
Of course, this is what they will do actually, because they give you an idea.
Yes.
Okay, so good to know from the people who already encounter the lay examiner, because lay examiner is something new for me, and most of the people don't know. So your information will help a lot of people. How many lay examiners will come in the exam? I think 4.
No,
Yeah,
I
yeah,
think
4 stations. 4 stations.
two. I don't know. In our course, there was two. There were two only. I don't know. Maybe in the exam.
In course only 2. Okay. Because in strategy they have written like 4 will be lay examiners, and these stations are high scoring
Yeah, I saw
stations.
also.
Like,
Mm-hmm.
yeah,
Yep.
like they will mark you
Mostly
more
the
if
history
if
of
they like you.
yep.
Yeah, if they like
History of
you will
termination,
score in that
pregnancy.
stations.
Yes, one lady, she was raped by her uncle, so she was
Yes.
not trying. She was not telling you anything, so you have to inquire
Hmm.
her, be empathetic with her.
Hmm.
Like this stations.
It was in the RCOG course?
Yeah, in Riyadh last month.
So you enter and you find a female or a male that you need to talk with in lay examiner.
No, she was a female. I didn't
So a
talk to her. In the end, when because they were also giving us feedback after every station, they used to give us feedback. So the examiner gave me the feedback, and the lay examiner, she also gave me the feedback, and she gave me in every in every domain, she gave me two. So I was very happy with this station.
Yeah. So actually, how you do it? Can you please tell me?
Actually, the girl was she was very young girl, 17, 18-year girl, and she came with the for the termination of pregnancy. So when I inquired her, she also had another history of termination of pregnancy. So I asked her what was the reason why you had termination of pregnancy, and she didn't want to tell. She said, this is the dark side of my life, so I don't want to tell you. Then I just like made rapport with her, and I told her that it's very important for me because I need to know that what was the mode of your termination, because it's also important for me in this for this termination of pregnancy. Then she said something that she was raped or something like that. So then I reassured her, and then like only empathetic approach, and I took her into confidence. Then I discussed with her this termination of pregnancy for this pregnancy, medical, surgical. And when I finished the station, the examiner, she gave me the feedback. You should say this. And then another lady, she said, yes, you did very well. Then I came to know, okay, she was the lady examiner.
Okay. So good to know. Anyway, all of us can get benefit from this experience. Okay, thank you very much. I want to stop here because many of the people already left and it's already very late. So thank you very much. And there are some of the talk articles that I will be posting in the group.
Thank you very much, Dr. Samira. It was
And I
really
hope
nice.
Thank you so much,
everyone.
doctor. It was very nice. It was very helpful.
Yes, we discussed a lot of things, and believe me, I learned a lot
It was
from
so
all of you.
interactive. Actually, it was so interactive.
Yeah.
No,
So
it was really
I
very
liked
nice.
it.
Maternal medicine top. Yeah.
Yeah. So good. And all of you will pass, whoever participated in the, but just 3 things I want
Inshallah.
everyone, inshallah. So 3 things. Read the question well and write the bullet points of the issues. Never miss anything in the question. Write bullet points. What are the issues? This is very important. The other thing, when you go inside, take care of your time management. This is the second important thing. You are responsible for your time management. And the third thing is be targeted. Don't say extra because you don't have time to say extra. Be on, so play straight. And then while you are, for example, at the end to the role player simulated patient, never ever forget to say, I'll offer you patient information leaflet and I'll offer you follow up with me, or if she need multidisciplinary care, or never ever forgets few points which they are very obsessed about, like in pregnant lady, don't forget about VTE risk assessment, don't forget about multidisciplinary team management, and some safety points needs to be mentioned, like allergies, referral to the consultant, fetal maternal or multidisciplinary team, and if the patient is on any particular medication that can harm her pregnancy. Every station has some particular safety points and some have general safety points. So never forget about these, to mention these safety points. If you have some lack in your from your knowledge point of view, so you can still pass the station, but just concentrate on these points so that you will not fail any station if you will fulfill this criteria, if you will fulfill the examiner with this criteria. If you have not done well, according to you, that you have, there are 5 points but you mentioned only 2 points, or you did not mention anything, unless it's not a blunder, unless it's not a safety point, then it's okay. But you have to mention the issues, you have to touch the issues what is in the question. So you have to read the question very well. The 2 minutes outside is very critical and very crucial for you to pass this station. If you have mentioned everything from A to Z about chronic renal failure and you did not mention about the teenage pregnancy, the chances are very low. So that is why I'm repeatedly saying that concentrate on the question. 2 minutes, we were not having 2 minutes, we were having 1 minute. So 2 minutes is more than enough to write the bullet points, important bullet points. Okay, thank you very much.
Thank you.
This conference will now be recorded.